So welcome everybody. I think we are ready to start. Can I have my slide on, please? Yes. So welcome to the Updates in Heart Failure 2025. I'm Gianluigi Savarese. I lead heart failure and arrhythmia research at Karolinska Institute at the South General Hospital. It's a pleasure to welcome you in Stockholm. And you are here, but we have also many participants who are online. So more than 10,000 colleagues are actually following us from all over the world. This is the third time we meet for this meeting, and I really do hope we will see each other also next year, just before Christmas in the lovely Stockholm. The meeting is organized by Karolinska Institutet and the South General Hospital here in Stockholm, and I will start to thank very much TMA, which took care of setting the logistics for this meeting. Many faculty colleagues coming from US, Canada, and Europe. So, you know, it's a big organizational effort. I would like also to thank all the sponsors which actually made this possible. Without them, this will not just be feasible. And say that I would like to ask the head of the Department of Clinical Science and Education at Karolinska Institutet, Professor Melian, to just give some words for greeting. Thank you.
Thank you, Gianluigi. It's a great pleasure to also welcome you from my behalf, from the department, from the Karolinska Institutet, Stockholm. Apologies, we can't offer you Stockholm in winter colors, but nevertheless, I wish you really two fruitful and scientifically fantastic days. Last week, we celebrated the Nobel Week and the discoveries that led up to the Nobel celebration and awards. Let's continue the discovery, the science, the collaboration, the international network. I am pleased to see so many international guests here today, but also to extend the discoveries into clinical science. And I'm very glad to see that this is about implementation in clinical practice. I'm a pediatric allergist, pediatric pulmonology myself, so this is a bit outside my field of expertise. Although, again, don't forget that children also one day become adults, and the early origins of disease is important also for the adult heart failure, I believe. So with that, I welcome you. I wish you two really fruitful days. I want to thank Gianluigi and the team and the department for the organization and the funding and the sponsors, of course. So with that, welcome and good luck with the meeting.
Thank you so much. And just a few words also from Professor Hoffman, who is actually head of education and research at the South General Hospital. Robin.
Yeah, thank you very much. I'm very excited to be here. I together here with my colleagues who will introduce themselves very soon. We are very proud to have so many international experts here in Stockholm, and from the Department of Cardiology at Södersjukhuset. I extend my gratitude for you coming and joining us in this busy time of the year. So most welcome.
Thank you. Just 1 second before we start the session. The first session will be on translating guidelines into practice, status of barriers, and strategies to foster GDMT implementation. And since we really want to be on time, and I would really invite all the speakers to be in time with their presentation, which is 10 minutes, in order to have a very fruitful discussion. And say that, I just leave the words to the chairs of the meeting.
And by that, we kick off our first session, as Gianluigi has just presented. I'm chairing this together with Robin Hoffman. My name is Camilla Hage. I'm from Karolinska University Hospital in Stockholm. And as co-chair, we also have on screen Professor Agarwal from India. And
Riccardo Chardi. Good morning, everyone, from the University Hospital of Brescia in Italy. It's a great pleasure to chair this session. Camilla, please.
Yes, and then we introduce our first speaker, Felix Lindberg, and he will talk about the gap between what guidelines say and what physicians do, the status of GDMT implementation worldwide. Please.
Thank you for the kind introduction, and thank you to Gianluigi and TMA for organizing this event, and especially thank you for letting me to go first before the other distinguished speakers have set the bar too high. So it's my task to give an overview of the current state of implementation of guideline-directed medical therapy for HFrEF. And I would like to start off by just acknowledging that we're talking about a syndrome where 1-year mortality is still approximately 24% 1 year after diagnosis, and that the available core pillars of pharmacotherapy have an estimated accumulative benefit corresponding to a number needed to treat of just about 4 for preventing a death at 2 years. And this stark need for treatments is contrasted by what we see in real-world registries. So here we have registries from North America, Europe, and Asia showing that under-implementation is a pervasive issue across regions. Although most patients receive beta blocker and a RAS inhibitor, only 30 to 60% receive an MRA, and of those patients who are on treatments, a minority receive them at target doses. And similarly, the global phenomenon has been reported by Report HF, including 18,000 patients from across 44 countries, showing that the lack of implementation is really a global issue, extending across country income levels. Now, these data that I have just shown you predate the 2021 guidelines and the introduction of quadruple pharmacotherapy for HFrEF. And they also predate the transition in the adopted approach from a conventional sequential approach to a parallel initiation and titration of pharmacotherapy. And now we have some more recent data here from the Titrate HF study from the Netherlands, including approximately 4,000 patients between 2022 and 2024. And now this is a registry setting and a rather well-resourced setting, but following the adoption of this parallel approach. And they showed in Titrate HF a slightly higher adoption of quadruple pharmacotherapy than prior studies. Approximately 44% of patients prescribed quadruple pharmacotherapy. But even in this registry and well-resourced setting, only approximately 1% received 4 drugs at target doses. If we now look closer at the registry we have here in Sweden, the Swedish Heart Failure Registry, zooming out a bit, comparing where we were some years ago to where we are now, we can see some progress. On the left-hand side, we can see between 2003 and 2012, there were limited or no improvements in the adoption of heart failure therapies. And following 2016 to 2023, we have seen an uptake across all drug classes over time, particularly following the 2021 guidelines, rapid adoption of SGLT2 inhibitors and quadruple therapy reaching approximately 60% by 2023. And similar findings have been reported from the Norwegian Heart Failure Registry, improved implementation across drug categories following 2021. And these observations are by no means causal, but I think it's interesting to note that the periods where we have observed improved implementation in Sweden, Norway, we have also observed improvements in heart failure outcomes. To the left, we have decreasing numbers of heart failure-related mortality in the general Swedish population, and to the right, decreasing heart failure hospitalizations in Norway. This study from last year in JAMA Cardiology tried to put a number on the evidence implementation gap on a global level. They tried to quantify the potential impact of optimizing GDMT to all eligible patients worldwide, and they estimated that approximately 20 to 25 million patients with HFrEF were eligible for GDMT, but also that there was substantial underuse. And incorporating real-world event rates and the efficacy observed in trials, they estimated that globally and on an annual level, approximately 1.2 million deaths could be averted by moving from the current implementation to one where all eligible patients receive GDMT. So what are the potential reasons for why we do not achieve GDMT in our patients? Last year, we published this survey where 400 physicians, slightly more than 400 physicians, got to list the barriers that they viewed as most clinically important for the underuse of GDMT. And not surprisingly, clinical barriers linked with poor tolerability or contraindication of GDMT, such as hypotension, renal disease, and hyperkalemia, were among the most common responses as barriers. But when we look at actual registry data from the real world, where we try to map out the actual reasons observed in registries, these clinical factors appear to explain only a minor part of the underuse that we observed in registries. For example, from HELP-HF, we can see that approximately 55% of patients underdosed with MRA had no apparent clinical reason to do so. And similarly, from Titrate-HF, documented side effects and intolerance appear to explain less than a third of non-use of GDMT. Another frequently cited barrier was patient adherence. But here, if we look at the EPIC-HF trial, where they collected reasons for non-intensification of doses during the trial, the combined proportion of missed non-intensifications due to patient adherence and patient preferences appear to account for 2% or less. And clinical inertia was a much more prevalent reason. So there appears that other factors must be part of the issue. And here we see a cross-center variability in the use of GDMT across different studies. To the left here, we have from Titrate-HF, the across-center variability in the achievement of quadruple therapy, which was 25% among the lowest centers and up to 75% in the most successful centers in achieving GDMT. And from SWEDHF, we have observed very similar numbers across the centers reporting to SWEDHF. And this observation that some centers appear to do very well in implementing and other centers appear to do much less well appears to suggest that organizational factors must play a role. And a critical organizational factor playing a role appears to be the access to dedicated cardiology and heart failure resources. In Titrate-HF, patients treated in a dedicated heart failure unit were much more likely to achieve quadruple therapy. And similarly, in SWEDHF, we have observed that follow-up in a specialty unit compared to primary care is independently associated with higher use of GDMT. So where do we move from here? I think the issue of implementation is growing increasingly important and also increasingly complex, with an increasing number of evidence-based therapies that should and can be offered to patients. And this development is likely to continue into the future. And this development places a greater need for implementation science to better understand how we can translate the therapeutic advances into real-world outcomes. Now, the solutions to improve implementation are unlikely to contain a one-size-fits-all solution, but rather different approaches must be used in different clinical scenarios and different healthcare systems. And some of these tools were outlined in a position paper published last year from the HFA on how to address clinical inertia in HFrEF. But I think that two common broad strokes appear as likely factors that could improve implementation across many different settings. And those are improved access to cardiology resources and cardiology care and cardiology follow-up, and also improved implementation of real-world registries that are live databases that can serve as monitoring tools for monitoring the actual implementation, and also for platforms for either screening for under implementation or for conducting implementation science studies. Thank you.
Thank you. Thank you very much, Felix, for a very elegant presentation. For the sake of time, we will move on, and as Gianluigi pointed out earlier, we will have a common discussion at the end of the session. So now I'm very happy to announce another very well-known heart failure specialist, Professor James Burton from the University of Leicester. Welcome. Thank you very much for coming.
Thanks, Robin. So I'm the nephrologist in the room, and I've got 10 minutes to tell you everything about what Felix mentioned, which was about CKD being one of the barriers to GDMT. And Robin even said if you could do it in less than 10 minutes, James, that would be absolutely fine. So I've got some declarations. But look, this is from the AHA presidential address. I'm sure you've all seen it. And I use it to highlight just how aware we are becoming of the crossover of cardio and renal and metabolic disease. And we shouldn't need guidelines or statements to tell us how important it is to work together in that field to make sure that we optimize outcomes for people with heart failure, CKD, and metabolic syndrome. But nevertheless, it has been highlighted. And I'm going to come back to this, and it's an absolute privilege to be here as a kidney doctor, talking about how we can collaborate. And I'm going to get you to reflect on a couple of things, I hope, from my view as a kidney doctor. And one, this is from KDIGO, it's our international guideline group, and I've just highlighted at the bottom, I'm going to read that out. Use the same principle in people with CKD to diagnose and manage cardiovascular disease and atrial fibrillation in those people who don't have kidney disease. So why do I highlight that? I highlight that because people with kidney disease are treated differently. They are treated differently. This busy table is from the MINAP database in the UK of 300,000 people who were treated for a non-ST elevation MI over 15 years in the UK. 10% of them had CKD because that's the prevalence of CKD. And so this is a comparison of how those people with CKD were treated against those people who didn't have CKD. And you may say to me, well, of course they're treated differently, James, because they might get contrast. Well, we could talk about that. But look at every single one of those treatment options is different between those two groups. And these data are from 2024, I think, based on that. It's in the last couple of years. This isn't about whether they had a big dose of contrast for their stent or PCI. This is about whether they are discharged on aspirin or not, or dual antiplatelet therapy, or whether they get a beta blocker or a statin. People with kidney disease are treated differently. And it is a huge barrier to GDMT. If we can't give people aspirin and a statin after a heart attack, then what are we doing for GDMT in people with heart failure? So my question was to think about what are the barriers to that? Well, one is around creatinine. So I'm sure you've all been in that situation where people come in with heart failure and they're diuresed and their creatinine goes up and the diuresis is weaned back. Well, this is just a reminder that actually this is survival for people with heart failure. And people who leave hospital who are congested with a raised creatinine do badly. People who leave hospital without congestion and with a normal creatinine do the best. But in between that it is better to leave hospital without congestion and not worry about the creatinine than it is to worry about the creatinine and they leave hospital with congestion. Does that make sense? Because those people who are congested would do worse. So if we focus on their creatinine and we withhold important treatments, those people will die sooner than if they didn't have CKD. The same is true for ACE inhibitors. The STOP ACE trial, which looked at the use of ACE inhibitors in people with GFRs of less than 30, we know from a kidney point of view that it will not accelerate or indeed slow down their progression to kidney disease. It is safe to continue from a kidney point of view, but those people who need those medications for heart failure are then not prescribed them because we have a culture, a thought that ACE inhibitors in people with reduced kidney function is somehow not good for their kidneys, that they are nephrotoxic. And that is just not true. That's a terrible terminology. And that's the outcome from the STOP ACE trial. No different from a kidney point of view, but important from a heart failure point of view. And we also know that if we think that we're doing someone a favor by giving them 2.5 milligrams of Ramipril or 25 milligrams of Losartan, we are just not. It is much the same as being on a low dose as being on no dose. And you can see that there for people who are on, whose RASI therapies are stopped versus those that are continued at full dose and those with a down titrated dose. So look, RASI therapies are important, really strong evidence base. We know that. We should be continuing them at the highest approved dose. And yet the creatinine is a significant barrier to that. So I'm going to show you the most recent guidelines for heart failure from NICE in the UK from September of this year. Look at that at the bottom. If a creatinine increases by more than 50%, 50% of their potassium concentration goes to above 5.5. I am sure many of you would have thought that the raise in creatinine would not be as high as 50% to be of concern. It's just something to bear in mind about our practice. Okay, hyperkalemia. I just want to mention that we've got some talks coming up about hyperkalemia. It is a barrier. And we often down titrate the RASI doses. We think 1.25 milligrams of Ramipril is better than nothing. It's not. And we do that because of potassium. So I highlight this from KDIGO just to say, if you look at the middle column, hyperkalemia, there are many steps that we do, including the use of potassium binders well before we think about down titrating disease-modifying medications. And that is important because we know that it works. So this is a meta-analysis of the use of potassium binders and optimization of RASI therapy in people with CKD or heart failure. And you can see that actually optimization of RASI therapies across a number of different trials, if people are on potassium binders, their RASI therapy will be optimized. So first of all, we've got to get them on, as Felix said, we've got to make sure they're on their GDMT, but potassium binders will definitely optimize RASI therapy. They definitely reduce the risk of hyperkalemia events, and we've got more talks about that. It definitely standardizes and brings potassium into the normal range and optimizes their use of GDMT with no signal of increased adverse events versus those not taking potassium binders. I've got 2 more slides left and 2 more minutes, so I'm doing very well. Robin is smiling at me. To just come back to this idea of really working together on this. I'm sure many of you will be doing more cardiorenal metabolic clinics, and there is absolutely no doubt that having the expertise of different specialties with different lenses in the room brings added confidence in managing those people with diabetes and heart failure and CKD that so often coexist, and using the individuals that we have, whether that is specialist nurses, pharmacists, or doctors. So I'm going to just mention one thing about an integrated. I absolutely accept what Felix said about the access to specialist advice and knowledge, because I don't think it needs to be access in a specialist clinic. It's access to that specialist advice and knowledge. And what this graph shows is the prescribing of finerenone in GP practices who have access to us in an integrated care setting. And I say us as nephrologists. And this was published just last month. So this is the prescribing of GDMT, specifically in finerenone for the management of CKD, in those primary care networks where they have regular monthly meetings with a nephrologist. And you can see in orange, so yellow are those GP practices in Leicestershire without regular access to that, and orange is the national average. So there is no doubt that access to specialist knowledge increases confidence and increases GDMT. So just to remember, so people with CKD are treated differently, and we need to get past that, focus less on numbers of creatinine and potassium and more on solutions, which I know we're going to talk about. And the best way to do that, I think, is to have more things like this and more opportunities to work together. And I'm going to stop there.
Thank you so much. Perfect.
Thank you, James. It was very great presentation, and we actually touched the point that we are going to discuss in the next presentation. And I'm very pleased to present Gianluigi Savarese, that will talk about hyperkalemia as a barrier to treat patients with heart failure. Please, Gianluigi.
Thank you so much. And as already been introduced by the previous speaker, this is a very important topic. Hyperkalemia is indeed one of the major barriers to the implementation of GDMT. You see that is very prevalent in patients with cardiorenal metabolic disease. And another very important point is it's recurrent. It means that patients go through several episodes of hyperkalemia, and together with increasing number of episodes, also the time between one episode and the other becomes shorter. So that's an important topic to be discussed in the setting of GDMT implementation. There are some subgroups of patients who do have higher risk of hyperkalemia, and these are definitely patients with heart failure and patients with CKD, and the risk increases together with more severe CKD and more severe heart failure. And patients with diabetes, of course, have also increased risk of hyperkalemia. And we see that patients receiving specific GDMT, such as, for example, MRA, RASI, have higher risk of hyperkalemia, of course, due to the fact that these drugs affect the metabolism, the homeostasis of potassium. But whereas some factors, some risk factors are irreversible, we cannot just remove heart failure, CKD, or diabetes. Some are reversible, such as CKD, such as RASI use and MRA use, but we should consider these as irreversible as well, because whether we do actually withdraw this medication, we increase the risk of mortality and morbidity in these patients. So do not consider RASI and MRA use as actually reversible, but irreversible risk factors for hyperkalemia. And you see that this condition is very heavily associated with increased risk of mortality. So it's something we really need to learn how to handle in our clinical practice. With an incidence of any hyperkalemia event in patients with heart failure across the ejection fraction of around 25%. So that's a very very important and to keep in mind. But part of the fact that hyperkalemia is linked with increased risk of mortality is not due to hyperkalemia per se, but is due to the fact that because of hyperkalemia, we might withdraw GDMT, which we know very clearly impacts prognosis. So we should keep this in mind, that probably by withdrawing medication, we actually harm the patients more than actually keeping them more than hyperkalemia per se. And this is a very important, according to the physicians, barriers to the implementation of GDMT. We investigated this in a survey we performed 2 years ago with the Heart Failure Association of the ESC, and you see that according 45% of the physicians who were actually surveyed, hyperkalemia was one of the major barriers to the implementation. You see also that the first reaction of physicians to hyperkalemia in many cases was withdrawn of RASI and MRA in a very, very high number of physicians, so over 55% of physicians were actually reducing dose of MRA or withdrawing the treatment. Very few used K-binders, and you see that actually physicians were reacting even to potassium levels over than 5, which might highlight even some overreaction to the problem per se. So whether withdrawal of MRA is frequent in patients with hyperkalemia, the other problem is that in a majority of cases, they don't get reinitiated when the episode is over, and this is very nicely shown in this slide, reported to be associated with very much increase in risk of mortality, which strengthened the message I provided earlier, which is part of the risk which links hyperkalemia to mortality is due to the fact that patients withdraw GDMT. And how to handle hyperkalemia? First of all, we should focus on patient profiles and the fact that different treatments have different pharmacological properties. And we should also keep in mind that some of the GDMT we use are not associated with increased risk of hyperkalemia, and therefore in some settings should be prioritized. First of all, don't forget that whether you use sacubitril/valsartan as compared to ACE or ARB, this is associated with less impact on potassium homeostasis, and as shown in the paradigm-HF, use of sacubitril/valsartan was working even as an enabler for MRA use. SGLT2 inhibitors in the EMPEROR program was linked to less discontinuation of MRA, likely mediated by the fact that the risk of hyperkalemia was reduced. And don't forget also that in patients with worsening heart failure, where you have a clear indication for vericiguat, actually vericiguat will be safe in terms of potassium levels because they are not impacted by this treatment. And beyond focusing on patient profile, you should keep in mind that novel K-binders have strong evidence supporting their use for optimization of GDMT use and handling of hyperkalemia. These are the key trials I'm going to present in the next very few minutes. This is the harmonized trials, patient randomized to SZC, different doses. You can see that in patients with hyperkalemia during 44 hours, actually the drug was successful in leading the potassium levels to normokalemia. Then at that point, patients were randomized to SZC or placebo, and you see that those randomized to SZC were able to stay in normokalemia range levels of potassium in the long term. So this is one of the two key treatments we do have in terms of novel K-binders for treating these patients. And if we go to patiromer, the second novel K-binder available, these are the results of the Amethyst. You see once again that there was a decrease of potassium levels linked with the initiation of patiromer, and which was sustained over the time. And when the drug was withdrawn, actually there was an increase of, again, potassium levels. So these are treatments which need to be used in the long term. When it comes to other evidence supporting the use, we here have the results of the DIAMOND trial, which indicates that the optimization of RASI is possible even in the setting of hyperkalemia. So indeed, in this trial, enrolling patients with a FREF potassium level were reduced by patiromer as compared to placebo. And very importantly, you see very clearly that those randomized to patiromer were able to maintain, more likely to maintain MRA target use. They had lower events in terms of hyperkalemia, and they could achieve more likely GDMT, higher GDMT use. The second key trial has been the REALIZE case study. This is on SGC. It included two cohorts of patients, one with potassium level between 5 and 6 and eGFR more than 6, and they were initiated or up-titrated with spironolactone, and whether they developed hyperkalemia, they were actually started with SGC. And there was also a second cohort. These were those on normal kalemia at high risk of hyperkalemia. They were initiated or up-titrated with spironolactone, and they were randomized to SGC or placebo, whether actually there was hyperkalemia developed. And major outcomes you see reported here assessed that 6 months were to stay on potassium level between 3.5 and 5, being on spironolactone at 25 milligrams or higher, and not using rescue therapy for hyperkalemia. So you see that the primary outcome was met with SGC as compared to placebo. You see also that the secondary outcomes were met, so there was actually less incidence of hyperkalemia in patients randomized to SGC, and less likely discontinuation of spironolactone because of hyperkalemia. The results were even stronger in older patients and in patients with eGFR less than 45, where the risk of hyperkalemia is even higher. There was a numerically higher risk number of events in terms of cardiovascular death or worsening heart failure in those who were on treatment, but there was also an imbalance in baseline characteristics in the two arms, which might explain that patients on SGC were sicker and therefore also at higher risk of developing hyperkalemia. Current guidelines recommend actually novel K binders in patients with potassium over 5 in order to optimize GDMT treatment. And this is just to conclude. Don't forget that hyperkalemia is not a topic typically of nephrologists or cardiologists, something that all physicians should enter in their when they meet the patients with hyperkalemia. Treatment with RASI is definitely a reversible risk factor for hyperkalemia. We should not withdraw this treatment. Whether a patient has an hyperkalemia event and this is and the risk of hyperkalemia is high, so there is no reversible cause for hyperkalemia, we should consider novel K binders for actually keeping patients on GDMT. Whether they are on novel K binders, there will be no need for additional potassium monitoring. Thank you very much for your attention.
Thank you very much for this slightly long but very nice talk. We will move on to the next barrier, which is hypertension, and we welcome Nicolas Girard from France on stage.
Thanks a lot. It's a pleasure to be here today. So I will cover low blood pressure in this talk. Sorry. Okay, is low blood pressure a problem? So this is my breakdown. For sure, low blood pressure in acute heart failure is associated with outcome, and it has been known for many years. But when you look at the dynamics of blood pressure, for sure, you have a huge increase of baseline low blood pressure with worse outcomes, but changes in blood pressure during the follow-up is nowhere near as much associated with outcome. And if you compare the association of stopping GDMT treatment with outcome, you're far higher with stopping drugs versus just having some blood pressure variability during follow-up. And so we try to address that in the SWEDHF registry, and I thank a lot the SWEDHF team letting me do this analysis within their major registry. So almost 50,000 patients with FREF, and for sure, low blood pressure is associated with outcome, but it's not really what's of interest to you as a clinician. Indeed, low blood pressure is less associated with outcome with higher dose of GDMT, right? So again, baseline low blood pressure is bad, but yeah, low blood pressure and the high level of GDMT is not as bad. And when you look again at the dynamics, when you decrease your blood pressure while increasing GDMT, tada, neutral association. So really keep this in mind in your practice. And if you break down further, according to GDMT level and blood pressure, and you can create some scenarios. So what would you prefer? Having SBP of 135 with less than 50% GDMT, so that's the red one, or 110 with 100% GDMT. So I'm in the 110, 1% GDMT team because the hazard ratio is 1.4 versus 1.9, right? Again, 110 under low GDMT versus 95 under 100% GDMT, I would favor the blue one versus the red one. But so for sure, this is observational. We don't have trials testing, strategies, but still, I think this is convincing to some extent. So I've been working on low blood pressure for a while. So we published the first review in 2020 with a French group, then a simplified version in an editorial in 2021, sorry. But I wanted to push this further, and I'm very thankful to the HFA for actually publishing a document, and I will cover this later. But first, some additional thoughts. One, stopping diuretics is possible in chronic heart failure, and probably you should take advantage of this while managing low blood pressure. So this is a reminder for the REBIC trial. So a small trial, about 200 patients, where you would retrieve diuretics in patients with 40 to 80 milligrams of furosemide a day. And basically increasing the furosemide again only when you are compelled to do so. And actually, and this was a placebo-controlled trial, right? And you can see here that there was no huge difference in reintroducing diuretics, meaning that you can safely stop diuretics in this kind of patients with minimal differences in NT-proBNP actually. Second, additional, thinking point, please keep in mind that a large proportion of patients with low blood pressure have actually low blood volume. This is a clinical observation, and I will skip this actually because time is running low. But if you have a person with a low blood pressure with minimal IVC, so very low volume, probably you can safely stop diuretics and, things will resolve. And I think it's a much better option than reducing GDMT. So this is the big piece, the big paper, the clinical management and therapeutic optimization of patients with FREF and low blood pressure from the HFA. I created something so that you can access to it directly. I will break down rapidly the different major figures that are within this document. First, no symptoms, SBP more than 80, don't bother modifying GDMT. Second, try to remove less important drugs, meaning drugs that are not associated with better survival. And typically heart failure drugs are associated with, better outcome, but a bunch of other things are not associated with hard endpoints. So probably remove those before touching the GDMT treatment. Third, assess the link between low blood pressure and symptoms and whether this is, something that is true outside of the hospital. And so we have put this table, tried to help physicians to take care of this kind of situation. So first, test for orthostatic hypotension. And if you have orthostatic hypotension, does it relate to symptoms? Because if it is not related to symptoms, then perhaps symptoms are related to something else. And if you do not have orthostatic hypotension, use ABPM to see, what's the blood pressure profile outside of hospital. And again, do you relate symptoms to low blood pressure on the ABPM? And then consider redo this if you find nothing, but don't jump on removing everything right away. So next step, for sure, if you have low blood pressure with a patient that is really not well, it may be cardiogenic shock, but it's just to push this aside from this story. If you have mild symptoms, probably it's better to do nothing, right? Having mild symptoms with maximum treatment that reduce majorly your risk of event is probably better than having no symptoms with a higher risk of death. And then, if you need to address this, we provide an algorithm to down titrate and re-optimize after, right? It's a touch and go approach. Don't down titrate forever. Okay, so another figure, the only thing that is truly important here is the breakdown of the drugs you may consider stopping before touching the FRF treatment. For instance, nitrates, antiarrhythmics, drugs for prostate, whatever, but try to get rid of things that are not related to outcome. And this is too complex for me to, go down the road of every scenarios, but the idea is to reduce one drug, but try to fix another problem if possible. If the patient has low eGFR, so perhaps you would decrease the drug that is related to both low blood pressure and low eGFR. Same for potassium. If the patient has decreased heart rate, so you may want to address both. And when you have an history of arrhythmia, then probably it's better to keep the beta blockers and try to decrease RASI first. But, this is a suggestion of patterns you may use to guide your down titration process. And for the acute part, I cannot go through everything, but the philosophy underlying this is keep in mind that GDMT is associated with lower neurohormonal involvement, and you need this to be relatively low if you want to decongest the patient. So keeping the RAS very high while you are decongesting is probably not a good idea. So it's better to keep at least some of GDMT pressure. This is the complex take-home messages we did in the paper, but my shorter take-home message is this one. If you can stay, and probably blood pressure is not that big of an issue. This is a maximalistic probably approach, but I would prefer stand up slowly than, having a skyrocketing risk of dying. Decrease diuretics whenever you can, and how to manage low blood pressure is relatively difficult. So please refer to the HFA clinical consensus. Thank you.
Thank you. Thank you very much, especially for keeping the time. I'm very impressed so far. I didn't even have to cough. So now I'm very happy to introduce Professor Alexandre Mebassa from the University of Paris in France. and he will speak about how to secure a fast and safe initiation of GDMT in clinical practice.
Thank you. Thank you very much for this 20-minute lecture. And it's a joke. Thank you, Gianluigi, for the invitation. I'm going to try to focus on the safe and initiation of GDMT, but before I would like just to make sure that we are all agreeing that heart failure is a cancer, and what we are doing here is giving a chemotherapy for cancer. When we did STRONG, in fact, this is the concept we try to show, is giving all the drugs together very quickly will markedly improve outcome. And in fact, we succeeded, at least by explaining this concept of cancer and chemotherapy. We could convince the cardiologist to give within 3 months, 6 months, almost half of the patient had full dose. This is really important, full dose of the 3 pillars that were tested at the time. And you can see that MRA was even higher. And what is interesting is giving a full dose of chemotherapy translated in improvement in outcome, as you can see here, within almost 6 weeks, but clearly at 90 days and 180 days, there was a clear improvement in outcome. Now, after STRONG, many people were saying, yeah, but this is a special scenario. Then we did other studies to really convince the whole world that heart failure is a cancer and we need to give chemotherapy. And we were helped by ESC guidelines in 2023 saying that really when a patient comes with an acute heart failure, we should have an intensive strategy of initiation and rapid up titration before discharge and careful follow-up visits. And I will explain later how we are going to handle those follow-up visits. And the 2023 guidelines said we should start the 4 pillars at a full dose. And what is really interesting and new for us is not only we treated heart failure, but also it was one of the most powerful decongestion strategy to give the oral heart failure therapies. I'm going to show you 3 studies that just were published really in the last even weeks. This study was done in Tunisia, named the CD study. What we did, we took patients with preserved ejection fraction, because still people are saying, yeah, but STRONG was not powered for preserved ejection fraction. We did it for preserved ejection fraction. For safety concerns, instead of having the follow-up visit done by the nurses in the hospital, half of the visits were done at home. Nurses were going at home. And maybe as importantly, or more importantly, we looked on because patient is coming for dyspnea, we looked on the respiration parameters, respiration rate and SpO2. And this was really a big surprise for us, 90 days after starting the full optimization, we could see that respiration rate, here at the left, and oxygen saturation at the right, 90 days after admission for acute heart failure were better in the patients who had the STRONG procedure compared to those who did not have the STRONG procedure. And we could also confirm that at 90 days and 180 days, there were an improvement in readmission and death. Here at a more broader level, here it's a study that was published few months ago now. This is China, more than 600 centers that were accredited to do the STRONG procedure. A small cohort of more than 400,000 acute heart failure patients. I think you would be impressed. At least I was impressed when I had those database. And the primary objective was readmission and death. The analysis was done like this. We had the data before accreditation and the data 1 year, 2 years, and more than 2 years after accreditation. I would like just to focus on the primary endpoint, death and readmission. You see, and this is really incredible, and this could happen in any country. If politically it is decided to accredit a center and teach them how to do the STRONG procedure, you see that within 12 months, we have an improvement in readmission and death. And you see that this is incremental. The more you are teaching the stakeholder, the more you are putting centers and more there is an improvement. And you see, by the way, that if you look only on the death, you see that death appears at year 2. Now, why this chemotherapy, why it is working in heart failure? And this is the paper from Jin Januzzi and from Harvard. They show that few months after putting the full therapy, you can see not only a small improvement in ejection fraction, which is clinically significant, but I feel maybe more importantly, there is a reverse remodeling and there is a decrease in left ventricular size, a decrease in mitral regurgitation. Now, everybody's saying, okay, this is beautiful, but can we really do it? The answer is yes. Please just follow the guidelines. And in the guidelines, these are the recommendations. But if you read the guidelines, it's said for every follow-up visit, indeed, you need to try to do them as early as possible after discharge from acute heart failure. You need to do a comprehensive visit, and comprehensive visit is really easy. 3 clinical signs, 3 biological signs. The 3 clinical signs are symptoms and signs of congestion, blood pressure, and heart rate. Nothing more. Biological signs are NT-proBNP, potassium, and creatinine. And only by having these 6 signs, 3 clinical and 3 biological signs, you can really easily handle your fast and optimal GDMT. Now, conversely to what our colleagues may think, and this is what Gianluigi and Felix showed earlier. In fact, we had a little of hypotension. Less than 10% of the patient had hypotension, very few bradycardia. But what we saw was a new congestion. In patients who are already congestive, if you add beta blocker specifically, you see new congestion. Let's look here on a patient who did very well. On the y-axis, you have NT-proBNP. When the patient comes to the hospital, you see that NT-proBNP goes down. And in fact, what is important is this point here, the NT-proBNP before discharge, crossing here the blue line and green line. You see that patients had the half of the dose of the 3 pillars. If at the visit week 2, NT-proBNP kept going down, then please, with no problem, you can go to full dose of beta blocker. In 1/3 of the cases, here again, having the NT-proBNP at discharge as really the important number to remember, we saw at week 2 that NT-proBNP went higher than even the level at discharge. And in that scenario, we paused beta blocker. And I think you heard it many times. Please never decrease and never stop those GDMT drugs. You should pause beta blocker, double the dose of diuretics, and in 96% of the cases, we saw NT-proBNP coming down. Then really, the main message is give the 4 pillars before discharge. It's very important for the patients to start to have the beneficial effect. It's like an oncologist who's giving chemotherapy as soon as the diagnosis of cancer is done, and try to see the patient as quickly as possible. And I hope I give you tricks to show that really it's very safe to give this chemotherapy. And if you would like to learn more, in a few days, HFA is going to do a webinar where we are going to enter into more details to explain the complex patients and how to handle them. Thank you very much.
Thank you.
Thank you. Thank you, Alexander. It was great. And I think we have a lot to discuss later on the implementation. I think that now we have kind of a switch before with Javed Butler, I think is online. Gianluigi suggested me to move with Javed. It's fine. Javed Butler. Oh, yes, as Gianluigi suggested. Javed, you are online, I think, right? Can you hear us? Javed? If he's not, okay. So if Javed is not hearing us, probably
No, I'm here. Sorry, I missed it. Is it my turn? I thought Marco was going first.
Yeah, Marco is after you.
Oh, okay. No problem. I will pull up my slides. Let me know if you see them.
Yep.
Okay. Can you see my slides?
Perfect. Yes, we do. Please, Javed. It's
okay.
pleasure to introduce
Thank you very much. Okay, thank you. So my apologies first that I'm not there in person, but really appreciate the opportunity. I've been coming to this conference for several years now, and hopefully we'll see you all in person next year. So I will take some liberties here and change the topic from what Dr. Savarese gave me. So the topic that was given to me, is there any new GDMT to introduce challenging Digit, HF, and Victor? My disclosures are at the bottom of the slide, and I changed the title to Why Challenge Digit and Victor and Why Not Embrace? So let me make a point of embracing both the trials rather than challenging both the trials, and would be happy to then take some questions. So let's start with the Victor trial first. So as we know, the Victor trial did not meet its primary endpoint. The p-value was not significant. There was a 7% relative risk reduction in the primary endpoint of cardiovascular death or heart failure hospitalization. However, we are left with this result, which we have never seen in a heart failure study before. We have had several trials there where both heart failure hospitalization and CV death were positive. We have many trials where heart failure hospitalization was positive, but not CV death, but never the reverse, where we had a positive CV mortality, but not heart failure hospitalization. The only exception to this is ICD trials, but they are obviously not heart failure therapy per se. So the question, and this result then translated into all-cause mortality benefit that was also statistically significant. So it all basically boils down to whether we believe in the mortality result or not. And if you do not hit the primary endpoint, should you ignore this signal? So I would first mention that this mortality did not come out of the blue. This was a hypothesis which was tested after the Victoria trial. Remember, in the Victoria trial, if you not include patients with advanced heart failure, and you take those patients with the lower 3 NT-proBNP quartile, which was 5,300 or less, this was a paper published by Michele-Seni, showing about a 20% relative risk reduction in cardiovascular or all-cause mortality. In the Q&A, we can discuss whether it is fair to exclude the top quartile or not. But the bottom line is, when you look at continuous analysis, it went up to an NT-proBNP of 8,000. When you look at less than 6,000 NT-proBNP, you're seeing this mortality signal. This was actually part of the study design for the Victor trial. So Victor trial had two aims: not only to look at the extension of the benefit of vericiguat from worsening heart failure to all heart failure without worsening heart failure, but in the study design, based on that lesson, NT-proBNP was restricted to less than 6,000. So that was a prospectively designed study. And two, the trial was powered for cardiovascular mortality unconditional to the primary endpoint being positive. In other words, there was a 80% power regardless of what happens to the primary endpoint, and the trial was to continue till about 600 cardiovascular mortality events occurred. So this is not a chance finding. The study was designed both NT-proBNP and the primary endpoint. Now we can again discuss, well, if you wanted to see cardiovascular mortality, why wasn't cardiovascular mortality the primary endpoint? We can discuss that. But I just want to highlight that less than 6,000 was part of the study design, and that it was powered for cardiovascular mortality regardless what happens to the primary endpoint. And then on top of that, in this very stable population, with half of them never having passed heart failure hospitalization and on medical therapy, which has been unmatched in any other clinical trial, including the use of ARNIs and SGLT2 inhibitor, whatever the mortality results we saw was on top of the best possible medical therapy that we have seen so far. Also, the results were internally consistent that the two components of cardiovascular death, sudden cardiac death and heart failure-related death, that account for, in HFrEF population, about 80% of the CV death, both were statistically significantly reduced, And both were reduced to a magnitude which I think all of us would consider clinically meaningful. 25% reduction in certain cardiac death, which was seen. The curve started separating at about 4 months and became statistically significant at about 5.4 months. And about a close to 30%, a 29% relative risk reduction in heart failure-related death. Now, again, I only have 10 minutes, so I don't have enough time to discuss the other thing. We can discuss that maybe in the Q&A of why wasn't the hospitalization benefit seen. We have seen over the trials that more and more care is being given in the outpatient setting. There's a whole another academic discussion which is occurring about outpatient worsening heart failure. We saw that in Paradigm trial, it was less than a quarter of the patient, about 50-50 in the SGLT2 inhibitor trial. And in the Victor trial, it kind of reversed, and 60% of the events were in the outpatient setting in these stable patients. These outpatient events were associated with high risk of mortality, and if you include them in the definition, you start seeing a statistically significant benefit. Again, happy to discuss this in the Q&A session. So now let's move on to the DIGIT-HF trial. This trial was looking at digoxin in the modern era of medical therapy. Original trial was designed for over 2,000 patients. With enrollment and other issues, eventually ended up with about 1,200 patients overall. Was followed longitudinally for clinical endpoints. There were 2 strata of enrollment, either EF less than 30%, or if you're between 30 and 40%, then you need to have advanced class 3, class 4 symptoms. And that's what the trial primarily enrolled, was advanced heart failure symptomatic patients. In terms of the baseline medical therapy, again, very good baseline medical therapy like the Victor trial. The only exception was that SGLT2 inhibitor use, because of the temporal changes in SGLT2 inhibitor use, was very low, about 19%. And SGLT2 inhibitor obviously has the same interaction with the primary endpoint of this trial. So that is the only thing that raises the question about the results if the SGLT2 inhibitor level was high. This trial also was positive, statistically significant. The primary endpoint, all-cause death or first heart failure hospitalization, there was an 18% relative risk reduction, which was statistically significant. If you look at the 2 components of the primary endpoint, neither of them were statistically significant, but the magnitude was almost the same as the primary endpoint, and I would assume that a large part of it was related to the lower number of events because of the small sample size, not necessarily the benefit. Even this merging of the curves that we see towards the end is likely because of the fewer patients, fewer follow-up, fewer data, those sort of things. So they looked at a whole variety of secondary endpoints, and there are 2 ways of looking at these data. None of these secondary endpoints like sudden cardiac death, death from non-cardiovascular causes, other combinations of endpoints reach statistically significant. But I would suggest that most likely this is because of not having adequate power overall. So the question is, where do we go from here now that we have these 2 trials? And the fundamental question is that every single heart failure paper, every single presentation starts with the epidemiology of heart failure. And do we believe in what we say when we present those data? We all say that heart failure has as bad a mortality as many forms of cancer or worse, that the 5-year mortality for these patients is close to 50% or so, regardless of EF. And in the HFrEF population, despite quadruple therapy, you have a residual risk of about 1 in 5 to 6 people dying or getting hospitalized within 1 year. So yes, we have come a long way with the quadruple therapy, but there is substantial residual risk in these patients. And this is the network meta-analysis by Adrian Woers and Jesper Trump and their group, showing that addition of further medication leads to significant reduction in the risk of mortality. So at least the way that I am seeing it is that for vericiguat, if the patient is intolerant or contraindicated to one of the 4 GDMT, then I think it's a no-brainer that it should be added. If a person is unable to take at least 50% of the doses because of creatinine, potassium, blood pressure, whatever, they are on really minuscule doses, then I think it also makes sense. The fundamental question is, What if the patient is not intolerant to anything? They can take the 4 medications, and that's where this issue comes up, whether the community believe in the mortality results or not, both in terms of the residual risk for mortality and in terms of the study design and the way it was designed, even if you did not meet the primary endpoint. And for digoxin, yes, there is this issue of a smaller trial, fewer events, and the fact that SGLT2 inhibitor use was low. On the other hand, however, we have seen that in the previous DITCH trial also, and we are seeing now as well, that at least in my mind, if you give all the therapies and people have persistent advanced symptoms despite optimal medical therapy, then it makes sense. And I will end my presentation with one last question, and that is that just suppose if you lived in the opposite world. Suppose if the VICTOR trial was not designed for mortality result, and suppose it hit the primary endpoint, was significantly showing reduction in hospitalization rate, quality of life improvement, everything, but there was a higher risk for mortality. Would we be willing to ignore mortality? So benefit in mortality and risk of mortality are two sides of the same coin, and maybe that's one way to think about it as well. Thank you very much.
Thank you so much. Introducing 2 more novel drugs, leaving us even more confused than we were before. We will now welcome Marco Metra, who will talk about the available weapons in worsening heart failure, which will be the last talk of this session.
Thank you, Camilla. Thank you, all the board. Pleasure to see also Ricardo on the podium. So that's a legacy that's continuing. And thanks to Gianluigi for his invitation here. My presentation was meant to be before the JAVED one. And just to say that VICTOR is what happens when you select patients who didn't have a worsening heart failure event or an heart failure hospitalization in the previous year. It's surely a kind of different patient population from what we were looking at talking about heart failure. Let's see if I can, these are my disclosures. So worsening heart failure. Worsening heart failure this is one of the slides that are most often shown in my knowledge, talking about heart failure. This is the trajectory of the patients with heart failure. And this is the trajectory of the patients with heart failure, and this is worsening heart failure, an event that is landmark in the clinical course of heart failure. It occurs in patients with a chronic heart failure, already a diagnosis. It must be kept different from early onset, new onset heart failure, and it generally marks a turning point in the clinical history of the patient, because we know that when it occurs, the patients are going to have a poor outcome. This is taken from the first universal definition of heart failure. Birkem knows much more than me. And we know that also in the first universal definition, and we remain also in the next one, we had these stages in heart failure, and we also had worsening heart failure as an event that marks the stage C heart failure and moving towards advanced heart failure. But worsening heart failure is also a red flag, as I said, a time in the course of the patient when we have to focus on the patient, learn that it is going to have a poor outcome, and optimize medical treatment as much as we can, and potentially refer the patient to a tertiary care center if necessary. Because of this, also in Europe, and with the help of Giuseppe, we wrote this paper as a Heart Failure Association on worsening heart failure. It came a few months later than the US articles, so it's a pity for us, but we outlined the characteristics of the patients with worsening heart failure. And I can clearly say that Giuseppe Rosano was the one that recommended to me this figure with a broader definition of worsening heart failure, not only the hospitalization, and this will be the main topic of my next slides, not only the hospitalization, but also a clinical event that can be characterized by, by new signs of congestion or even a decrease in exercise capacity. We may have a subclinical worsening heart failure, just shown by invasive hemodynamic monitoring. Let's think about a patient with a CardioMEM, but also imaging, or even better, biomarkers. An increase in NT-proBNP plasma concentrations may be a marker of worsening heart failure. And then we have the events and then the outcome. This was the first analysis by Scott Solomon showing in CHARM, Candesartan in patients with chronic heart failure, that when the patient was hospitalized, he had, compared to the outpatient, an increase in mortality that was from 4-fold to 16-fold. And so it started the paradigm of hospitalization equal to worsening heart failure, which is not true. And Javed has shown this, and I will come back to this. But this hospitalization is true, is correct. This is the analysis of the Euro ESC heart failure long-term registry led by Lars, and showing very simply that hospitalized patients had a increased mortality and heart failure hospitalization rate compared to outpatients. But then, as I said, we have to broaden the definition, and worsening heart failure includes also an unplanned visit to the emergency department because of breathlessness of the patients or signs of congestion, and includes also an unplanned outpatient visit where the patient says to us that he feels poorly, it has he has increased symptoms, and we detect signs of congestion and increase diuretic therapy, even oral diuretic therapy. How hospitalization can change was dramatically shown, but this is quite clear, by the COVID-19 pandemic. During the COVID-19 pandemic, these are the data from the London area, there was a dramatic decline in the number of hospitalizations compared to the previous year, despite an increased mortality. And then we have a retrospective analysis of randomized controlled trials showing the same. We have this from Paradigm HF, and you see that patients hospitalized for heart failure have a 5-6-fold increase in the number of events, but also the patients who had an emergency department visit for heart failure, or just the patient who had an intensification of oral diuretic treatment, they have a 4 to 5-fold increase in the event rate. Sorry, I don't see how much time I have, and I don't want to create problems. 3 minutes. And this is registry data, just outpatient intensification of diuretic therapy is followed by an increase in the event rate. And again, also these heart failure events are affected by guidelines-directed medical treatment. You see this from the Emperor Preserved trial that the empagliflozin reduced not only the primary event, but recurrent hospitalizations and also outpatient intensification of diuretic treatment. And you have already seen this from the VICTOR trial, showing how the epidemiology, the clinical presentation of heart failure has changed in these last years. And there has been a progressive decrease in the number of heart failure events leading to an hospitalization compared to paradigm HF, and a progressive increase in the outpatient events that now include 75% of the cases. And this is what Victor has shown, that if you just look at hospitalizations, you lose the effect of therapy. But if you have a broader definition of heart failure events, including outpatient intensification of diuretic treatment, you have a drug effect. So watch out for the next trials. Then we have signs of congestion as clinical signs of worsening heart failure, and we have a treatment that now more than before must include 5 pillars of drugs, so that not only neurohormonal modulators and antagonists for patients with HFrEF, not only SGLT2 inhibitors for all patients. Let's recall iron supplementation if the patient has iron deficiency, as shown in AFFIRM-HF, but also vericiguat in a patient with reduced ejection fraction, as shown in both Victoria and in the meta-analysis, to be effective in reducing heart failure rehospitalizations and more cardiovascular mortality. And again, the benefit, this has been already shown by Javed Butler, the benefits of quintuple therapy and the benefits of additive therapy. So my take-home messages are these: worsening heart failure characterizes the natural history of heart failure. It includes heart failure hospitalizations, emergency visits, and outpatient visits with a diuretic escalation. It is caused by congestion. It can be prevented by early detection of congestion, and its treatment and prevention pose a unique challenge with the need of optimization of medical therapy, including vericiguat. Thank you for your attention.
So thank you very much for this excellent talk. We now welcome all speakers on stage. And we will have a discussion of what we've just heard. All the questions from the floor are welcome. Please go to the microphones.
If no comments, I will start, and taking the opportunity to discuss further about the concept of including worsening heart failure event in our composite endpoint of design and clinical trial. And I will actually like to ask to Javed, we've been discussing a lot, especially in the last period of time, about the implication of oral diuretic intensification as a endpoint to include or not in the design of a clinical trial. And we recently have an interesting kind of sort of editorial of review on New England Journal of Evidence about the concept of what is exactly oral intensification, and if we should include it in the endpoint of future clinical trials, and in what kind of population you should use it.
Yeah, so it's a little bit of a difficult question to answer because can you hear me? Yeah.
Yes, we do.
The reason it's a difficult question to answer is that remember that there is a degree of uncertainty with any endpoint that you have. For heart failure hospitalization, there's a lot of uncertainty, right? We know that heart failure hospitalization reflects both the severity of the disease, but the local practice patterns, the number of hospital beds available in a community, all those things happen. But we as a scientific community, as an academic community, as a clinical community have accepted that degree of variation, and we include heart failure hospitalization as an endpoint because majority of them are associated with poor outcomes, but not all. We then had this whole robust discussion about IV diuretic in the outpatient setting. We had a lot of concerns that what if the patients are just inappropriately given IV diuretics because there may be some other incentives or whatever. We went back and forth and we created that. Now we are going through the same thing with oral diuretic intensification. So there are three categories, right? So if somebody is not on a diuretic, they're started on a diuretic. If they are on a diuretic, their dose goes up. And I don't know what these bubbles are. Sorry about that. And then the third is that if they are on higher doses of diuretic, a second diuretic is added. So all three of them are diuretic intensification. The struggle here, and the data are very clear that oral diuretic intensification is associated with poor outcomes. What is unclear is that how long it should be going up for, because it's very common practice for people to go up on a diuretic for 1 or 2 days if they gain weight, whether it should be associated with worsening symptoms or not. And those kind of things that the academic community will have to work through. And then the last comment that I will make is that there is a fear that if you have oral diuretic intensification as part of the primary endpoint, then all of a sudden it will be 50-60% of the primary endpoint. And now your hospitalization rates will be even low, mortality rates will be even low because of all of this outpatient oral diuretic. And if you win, will the payers and will the clinical community buy it as an endpoint? So this is a, very long-winded answer. That's a really important topic. And we should try to come up to a conclusion as an academic community. What are we going to do with it?
Please, Marco.
If I can add something. First of all, as you said, it's very important, and having registries like SWEDHF is very important to look at sensitivity of this event with respect of the outcome of the patients. So it may be that 1 day of intensification of oral diuretic treatment is just having eaten pizza the night before, and the patient can deal with 1 day of increase in Lasix, or it may be that even this is attended by a poorer outcome. So we need more analysis of registries with respect to this endpoint. But the other thing is that it seems to me that the regulatory bodies, including FDA, do not accept, and Javed, these do not accept this intensification of outpatient oral diuretic as an endpoint for a clinical trial and for approval. And so it would be important to have a meeting with these regulatory agencies to sensitize them, because, I mean, Victor has dramatically shown that this outpatient worsening heart failure event may make you lose the efficacy of a drug. So we need to sensitize regulatory bodies, I think, like we did years ago.
Lars, welcome.
Yeah, thank you very much. So going from trial design to clinical practice and unmet needs. So HFrEF stage C, enormous success. HFpEF moving in the field of metabolism adiposity, leaving, as I see it, the biggest unmet need, this worsening / advanced / C2D heart failure. And this is not really just including hospitalized patients in trials like in MPulse, because they are stabilized in hospital. What about those that are really not stabilized or truly progressing or really advanced, Marco. What is the physiology that should be targeted? Is it congestion? Is it contractility? Is it perhaps vasopressors? What's the next strategy looking over the next 10, 15 years in targeting this population where other trials have been not successful?
Thank you, Lars. You know what I answer. I cannot not think that myocardial contractility at some point becomes the limiting factor. In my mind, it's very easy because if the patient develops hypotension, meaning a systolic blood pressure less than 110, this is low cardiac output in the end for this patient, and so I think that a treatment working on the cardiac function should be effective, and the DIGIT-HF trial has clearly shown that even in nowadays there is room for improvement with this kind of treatment. Of course, it's difficult to demonstrate because, and it's the case of GALACTIC-HF, if you include patients up to 35% of ejection fraction, no matter what systolic blood pressure, so we had patients with 140 or systolic blood pressure. These patients do not need an improvement in cardiac function. So the trial must be targeted at the right population, but I think there is an unmet need for sure. Okay, good to see beer chemos, not vasodilators in this case.
We would also like to welcome our friends who sit in India, Professor Agrawal. How is it going for you?
Great. I think I've heard some great talks and lots to learn and discuss. Yeah.
Okay. So we take Oh, sorry.
I would actually. I think I just had a few comments to make regarding the talks, and one of the things which we, sort of lose sight of a forest for a tree is we don't really give too much importance to the role of cardiac rehab. And, with all the same drugs which the patient has on board, a patient who walks, who exercises regularly, who is under supervised cardiac rehab tend to do much better in the long run as compared to somebody who doesn't. That's number one point which I wanted to raise. The other is that we are underutilizing cardiopulmonary exercise testing as both a diagnostic test and as a prognostic marker. And I think that's something which should also be put on sort of as a priority for assessing these patients of heart failure in the long run. Because I think we underestimate the role of muscle in the outcomes. And that's one thing which is missing out in most of the trials is the effect of sarcopenia, the muscle mass, the exercise, which is, I think, very important in the overall prognosis of a patient of heart failure.
Thank you very much. We have another question here from the floor. Could you please state your name and where you're working?
Thank you, everybody. My name is Lavin F. Jaj. I'm working in Sankyoran, Apia Sankyoran. My question is about implementation of GDMT. Felix talked about getting access to a dedicated heart failure unit is an advantage. And James was talking about access to specialist advice and knowledge, not clinic, because that will increase the confidence for using the GMDT. So my question is, how do we improve access to information for the primary healthcare? Because they receive a large number of patients that have heart failure. It's a general question to everybody. So.
If I may start, your point is extremely well taken. I think that's a very important thing. And we should take advantage of, for example, the very good electronic health record system we have in Sweden, which facilitates very much communication across different clinics. And I think we don't do that enough. We just use the referral system just to, refer patients, but actually that could be also a very good way for you to get advice from more specialized settings and actually start to work on specific subgroups of patients directly in your clinic while the patient is referred to others. So that's how also the knowledge can be transferred across different clinics, and I think that will facilitate as well the work at different levels in primary care as well, where these patients are seen first, for then, in the meanwhile that they get referred to secondary care, where the waiting list is sometimes extremely long.
Yeah, thank you for the question, and I agree with Gianluigi. I think that with the increasing complexity of heart failure treatments, I think it's very difficult to expect that primary care, who deal with many patients with heart failure, but at the same time, heart failure is a very small proportion of their practice. And I think it's really essential to realize what we expect. And I think the focus should be on recognizing appropriate times for referral rather than trying to disseminate the knowledge to the primary care for them to manage everything with the support for cardiology. I think the study that James presented on the virtual consultations for nephrology clinics or for primary care centers who were having access to such a service, increasing the use of finerenone is a very interesting approach, and I think that might be sort of a hybrid approach that might be appropriate in some scenarios as well.
I'm just gonna say, I guess we're living in a time when earlier recognition of symptoms and earlier treatment and leading to prevention of disease and symptoms is really important, and the role that primary care play within that. From a CKD point of view, that's more acute, but even from a heart failure perspective, we need to recognize that people will see primary care and they will be altering doses of medications and changing GDMT. They will be down titrating RASI therapies in the context of hyperkalemia. Primary care have a really significant role in ensuring that people continue on their GDMT. And so I guess from my perspective, there's a couple of things. We have to make things really simple. We have to make the messaging incredibly simple. The second thing is we all need to do the same thing, because if we don't do that, then primary care just don't know what to do. If they get conflicting messages, that is incredibly difficult. And the third thing is that we found really key is not to go to primary care and say, this is how primary care should manage CKD or heart failure, but ask primary care how they need us to help them to do it themselves. And that is really key, because that empowers and activates primary care, and it actually, more importantly, will generally involve the patient in that and will keep them adherent to their medications.
Thank you. Nicolas and then Baikem.
Very quick add-on. We have published an analysis this year in European Heart Journal on all heart failure patients in France that the social security know of. So patients admitted for heart failure or under long-term heart failure status within the healthcare system. And so 700,000 patients, so 45% have not seen a cardiologist in the year before identifying them, right? So basically 1 in 2. So the great divide is paramount. Only 1 in 2 see cardiologist.
Baikem, please.
Hi, Bikram Baskert. I want to comment on the most final concept, but also in the stage C to D. Yes, we will all be treating different diseases with similar medications for the different proximate cause, even though the clustering of the risk is going to be very similar, because everybody eventually develops the cardio-kidney metabolic profile. Having said that, I think the standardization and multiple medications now are with rapidly expanding indications will probably eventually make the framework simpler. My comment was the concept of C to D, which is a critical component for us to recognize, is a trajectory of the patient at the patient level. We're looking at the trials at population level and or the trial population level, but at the individual level, 2/3 of the patients after initiation of GDMT improve. What happens to the rest is the story, and we've always assumed the one that is very advanced, stage D, is less than 1%, i.e., that was defined by the requirement for VAD and transplant, so that was limited to the availability of the advanced therapies. Therefore, we always kept it in that little container of less than 1% of the patients are D. In essence, what percentage is actually not improving? If you look at the mortality rates at 1 year, in the best scenario for stage C is 10%, 1 year. Sicker is 25%, the sickest is 50%, 1 year mortality. And therefore, and they're not dying, the majority of them are not dying from sudden cardiac death. What are these people dying from is progressive heart failure. And how do we define that? Is that trajectory, and thus it's going to be critical, like cancer did. How are we going to identify progression of disease? The way I see it is, if you're not totally becoming asymptomatic and resolved, and if you're with persistent symptoms, you have active cancer. And that requires further optimization. If you're worsening, my goodness, that requires referral and really important concepts for which we do not have targeted therapies for, and that's an area of gap. And yes, Digitalis, ongoing studies with maybe cardiac myosin activators and others, there's not a good phenotypic targeted therapies there. Majority, if lucky enough to respond to GDMT, will improve. But then what happens if they're unable to tolerate is the key. And this is not a small population. If you were to say 10% of stage C in the US, that's 500,000.
With this respect to the trajectory, I think a major problem remains for heart failure that we don't have a measurement. I mean, we don't have like incretins, we have body weight, and in addition to everything, I mean, kilos are very easy to measure. We had blood pressure, total cholesterol. I think we must emphasize more the role of serial NT-proBNP measurements, because I mean, to me, is the best parameter that we have. And if we measure them systematically, first for the early diagnosis of heart failure, first, because, I mean, we measure serum creatinine. Think about serum creatinine. What did it do for chronic kidney disease? And what we have for heart failure and cardiac dysfunction is probably NT-proBNP. First for the early diagnosis, but then also to follow the progression of the syndrome and have, again, a threshold. And this is my guess.
Marco, I would propose maybe a whole portfolio that the clinicians already are using in the following: hospitalization, you're worsening. ICD shocks, you're worsening. Unable to tolerate meds, you're worsening. Blood pressure is going down, you're worsening. We know what those are. I think we could give the discretion to the clinician to say, you're worsening, you're better. I know in the clinical trial realm, we'll need to come up with objective criteria. So I would look at the trial concept separately than the clinical practice. Progression-free survival in cancer relies not solely on symptoms and the tumor burden and the biomarkers. It's a constellation of all. I think we're going to get there in terms of the progression-free survival concept for trials. But for the time being, for the clinician to say, I don't think we should say you're stable, because that you're dying. That's what it means. If they're still symptomatic, I think the concept of is this improved and recovered and or resolution of symptoms, I think we need to get to that resolution of symptoms, especially for the one that is with, good, functional capacity, along with the ventricle looking better, biomarkers looking better and the rest, and that you're not getting hospitalized in between.
Welcome.
Tashi, I work at the South Hospital in the city here. My question is, in order to implement GDMT, we have these two parameters, blood pressure and CKD becoming a sort of a hinder. My question is, what is the evidence that we can go beyond the need to monitor blood pressure for the asymptomatic patients? Because, and the other thing is that the need to monitor GFR or creatinine, because the kidney doctor already said that the heart failure medication is good for the heart failure survival and does not seem to damage so much. And the hyperkalemia is a handleable situation with a lot of new kalium binders, so potassium binders. So what is the evidence? Can we go ahead having to need to monitor blood pressure and creatinine so that we can improve the implementation?
Nicholas, do you want to start?
I take the first part on blood pressure. We're probably monitoring it way too much. Yeah, let's have not that frequent look to blood pressure and will be less of a problem because then you have the nurses freaking out and the patient being, obsessed with it and measuring it all the time. So actually, I am arguing against using blood pressure monitoring within telemonitoring in France in the system that we have because of that, because it will create problems and actually not that much solutions. So I do agree with that for blood pressure.
From a creatinine point of view, I'm going to go with what Nicholas said, to be honest with you, for the same reasons. And I think also if the diagnosis is not in doubt, why do we measure GFR? Why do we measure creatinine? We measure it in case we need to change medication doses. I guess that's fair. We measure it for potassium, which isn't about their GFR, and that is also fair. And we measure it to educate patients and prepare them potentially for dialysis. And controversially, I'm going to say in the group of people who have worsening creatinine because of their heart failure, that is a conversation we need to have, but potentially those people are not necessarily the best dialysis candidates because we know that actually we will probably not increase their quality of life, and any years of life gained will be the time they spend attached to a dialysis machine. So we should be monitoring it less, actually. And in certain circumstances, so for example, I look after a lot of dialysis patients, and I'm often asked about the evidence for beta blockers and Entresto for dialysis patients and their outcome for heart failure. And I'll point you back to what I said earlier, which is we should be treating everybody with CKD the same as we should be for those who don't. And I would say that is true for dialysis patients. But actually, those with more advanced kidney disease, if you check the creatinine, the knee-jerk reaction is to down titrate or to pull back on the treatments for heart failure, which may not be the right course of action, I'm sure. And from a kidney lens, I would say that we have a similar thing about blood pressure. There's always that worry of treating the number rather than the person, because to a nephrologist, a systolic blood pressure of 90 in someone with heart failure and CKD, we might be thinking, we need to reduce the Entresto because it's the number that worries us. But actually, I now know, because I work much more closely with my heart failure colleagues, that if they're not symptomatic, then actually those medications are really good. So again, I come back to that idea of really talking to each other about it.
Lars?
I would nuance that just a little bit. I mean, I do encourage measuring blood pressure and GFR. And in fact, like Alex would probably say that too, because that's what enabled you to uptitrate so rapidly in strong HF, right? So do not only think of them as barriers to treatment, think of them as tools to increasing and improving treatment too. The problem is not that we measure it, the problem is that we overreact to it. So the key is that it's the clinical context and not the number. That's exactly right. But you also need it to be aggressive.
Can I make one point?
Yeah, of course.
So, I'm the nephrologist in the room, so I need to say this thing, is measuring ACR can be a really, really great tool in this actually, because every single medication that we are talking about at the moment will cause a rise in creatinine and a reduction in GFR. And people will look at that on their apps and say, that medication is harming my kidneys. But if we do a regular ACR for SGLT2 inhibitors, for MRAs, for finerenone, you'll see a reduction in ACR, and you can say to the patient, well, actually it isn't, because this is a more sensitive marker of scarring and damage, and you can show them an improvement in their ACR. So that's my slight plug that we should all be doing more ACR.
And, Can I make a comment?
Please go ahead.
Yeah. So, if we take a scenario where the patient's creatinine is going up, the GFR is falling, and there is also a blood pressure which is say around between 80 to 90 systolic. Now, I think that we will have to define permissible hypocreatinemia in most of these patients. If the patient is hypoperfusing and the creatinine is rising up when you're adding new drugs, I think that's the problem of deciding whether to continue or to withdraw. And I think most of us are quite comfortable if the blood pressure is, say, above 100, 110. But it's when it is borderline is when you will have trouble deciding whether you would want to continue with the ARNIs or withdraw them at that point of time.
So and that's absolutely right. But ultimately, our patients will die of their cardiovascular disease before they need dialysis. And so the key here is to keep them out of hospital for their heart failure, because the more we've seen very beautifully in a lot of the talks that, that worsening of heart failure and that point where they start to come into hospital more often, that is where they are at risk. And so it is a balance, but generally speaking, we need to react less. I think that was a really lovely turn of phrase, react less to the creatinine and think more about getting that person comfortable and keep them out of hospital by managing their heart failure.
Very short follow-up, and I do agree with Lars that in expert hands, it's very nice having the blood pressure, and even more so when you up titrate, not that much for down titration, right? But for up titration to see how much you can up titrate. For this, I agree. It's very important.
Probably Alex was going to say something.
Yeah, I would like to be even more provocative and say maybe we should not see the patient anymore. And in fact, we should make a difference between the up titration, where we should see them very, very often and measure what is needed. But I'm working with many, many centers now all around the world to say in the 50% of the patients who are really fully treated with the 4 pillars at a full drug, we decided, and I hope within 1 or 2 years we'll have the data, we decided to not see them before 1 year, even sometimes 18 months. Indeed, if they have a problem, they will call, and then we will see whether going up to 12 to 18 months, whether it makes any difference. And I think this will make a big change because it will give more rooms to our heart failure clinics. The patient is less anxious. And again, if they are fully treated, the question is, should we even see them again?
That's a good point. Bikim?
I fully agree with that comment on sometimes we treat the numbers rather than the patient, and the concepts probably we need to start formulating is, yes, hyperperfusion is the one that we're dancing around, blood pressure and the end organ damage, and maybe we need to clearly, as Dr. Agrawal pointed out, the Achilles heel is the shock, the pre-shock, and the hyperperfusion. And once and if the patient self-declares or we diagnose the patient, the question is, in what percentage of those will be able to continue or not. That's an art. I'm not going to go and mention that. The rest is okay, except for when we were coming to that eGFR of less than 25, which requires the help of our nephrologist. Now, the problem that I see is this, at least in the United States, the system is formulated and incentivized monetarily to stop care because the diagnostic related grouping of ICD-10 codes are enriched with AKI, acute kidney injury. In the US, if you code AKI for a hospitalized patient, the reimbursement is more. But you cannot get paid unless you do something for AKI. Whenever you code something, you have to do something. And if you are not doing something, you don't get paid. Hypoxia, you give oxygen. AKI, what do? Stop therapy. That's what all the hospitals, all of the administrators and the trainees are told to do. This is a problem, and it started with the AKI definition, which we now need to intervene on. AKI, I was mentioning this in some other forums, is the highest rising diagnosis in the world, not in the US only, everywhere. It's next to sepsis for all of the hospitalizations worldwide, and it's increases like this. It's almost like an epidemic of something. Nephrologists agree with us saying we shouldn't be coding, this is not AKI, but regardless of that, any rise, we're not talking 0.3 increase, 0.1 increase is coded as AKI because it makes it look more complex. For the outpatients, it also helps with the complexity of care and reimbursement. For that reason, we'll need to come up with KDIGO and others. In this setting, you cannot code AKI. Ban it, otherwise it's going to continue.
Thank you. Frieder, a short comment,
Yes, it's only
which will be the last one.
I just noted that we are a group of highly specialized academic center cardiologists or nephrologists or hypertension specialists. And as Felix mentioned in his first talk, highly predictive variable, which patient had a better prognosis, were those cared by specialty care, but as a matter of fact, significant proportion, or in Sweden, the majority of our patients is treated in primary care. And these are, as you know, older, more polymorbid, have maybe some kind of cognitive dysfunction and even more difficult to treat. So I think it's very important to seek this communication with primary care, maybe to invite them to meetings like this. And these simple messages like tolerate GFR increase, low blood pressure, high potassium is very important really to communicate with primary care. And we should be even better in seeking this collaboration.
Thank you very much for this very nice comment at the end. There's a lot more to discuss, and we have now the opportunity to do that over a cup of coffee, which is served here right to the left. And even thank you to all the speakers, great talks, but there's a lot of issues to be solved. Thank you also to our friends who are here online. And the next session starts at 3:10, treating cardiorenal metabolic disease. Thank you.
Thank you.
Yes. Yeah. They do. Let's go. Yeah. And one discuss. Yeah, well, we have 4 chairs actually because hey, Dr. Chatterjee is online. What? I know Daniel's on. I can still say. I don't mind doing that. And then we're just going to go through the.
Hi, for me. Good to see you. How are you? Good to see you.
Yeah, you probably know most people in the room.
So we have one more chair.
You just know people.
Great, totally tempted. Yeah.
How are you?
It's very good, great.
I'm fine, thank you. To be in Stockholm again?
Nice to see you.
But to allow the audience, if they do have, but maybe that we say so.
Yeah.
But we can each present one speaker going from that direction.
Should
I want to begin and then Francesco.
Fine. Welcome back to the room, everyone. Hope you enjoyed your refreshments. We're moving on to the second session about treating cardio, renal in the middle, the most important one in the middle, metabolic disease. I'm joined by some colleagues as well as Dr. Chatterjee, who's online to chair the session. And it's the same format as last time, where we're going to go through some talks and then we have time for discussion at the end. So I'm not going to hang around any longer, but to introduce the first speaker, Christian, who's going to talk about cardiorenal metabolic syndrome disease, the size of the problem. Thank you very much.
Thank you for the introduction. Oops. Okay. Very well. So my presentation is to set ground also for the other presentation of cardio-kidney metabolic syndrome. So I will talk to you about the size of the matter and why do we care about this. As you can see, cardio-kidney metabolic, we have defined it as a disease in 5 stages from 0 to 4, from no risk factor to actually established cardiovascular disease. But there are stage 1 and stage 2, which we'll focus more, where actually the size is extremely relevant. And let's start with stage 1, so the root cause of cardio-kidney metabolic, one may say that is obesity. Those are data from the global burden of disease. So as you can see, obesity has been rising. We know that very well. So much that from 1990 to 2022, the prevalence exploded both for women and men almost everywhere worldwide, to an actual prevalence of obesity of 18.5% for women and 14% for men. What about metabolic syndrome? We know so much that metabolic syndrome is important that we're actually now discussing to integrate liver endpoint in clinical trials in cardiology and kidney disease. So this actually gives you the importance of metabolic syndrome. What about chronic kidney disease? We know that the burden of CKD is huge. We're talking about 1 billion people affected by chronic kidney disease, with CKD being present in almost 35% of patients with diabetes, 1 in 4 patients with arterial hypertension, and 35% of patients with cardiovascular disease, with projection leading to a 24% increase in prevalence of CKD and up to 37% higher costs from now to 2027. So much so that CKD will likely be the fifth highest mortality burden by 2040. And if the prevalence is increasing, it could be by a lot of different stuff. Like for obesity, there is a shifting in the epidemiological data, but for CKD, maybe we are treating patients better. That's why the prevalence is higher. But on the other hand, maybe we are diagnosing more. I would love to tell you so, but this is not really the case. Those are data from the REVEAL CKD showing that 50 to 90% of patients with stage 3 CKD go undiagnosed. This is from electronic health record. But why do we care so much about CKD? Because as was previously said, in 5 years, patients with stage 4 CKD are way more likely, 50%, to die from cardiovascular causes than to go into dialysis, 18%. So this is not a nephrologist problem. This is everyone's problem. And CKD and type 2 diabetes are strongly intertwined, so much so that for 600 million people living with diabetes, projected to be around 1 billion by 2045, and with 90% having type 2 diabetes, 2 in 5 have CKD. And we are not getting that much better in preventing kidney failure in patients with diabetes. Those are data from US adults with diabetes, and you can see that of all the complications of diabetes, we are getting better and better in lowering acute MI, stroke, amputation, and death for hyperglycemic crisis, but not so much in kidney failure. Last part of chronic kidney metabolic syndrome is arterial hypertension, and we know very well that arterial hypertension prevalence is increasing, has almost doubled in the last 20 years. And we know very well from meta-analysis of previously performed randomized control trial how important it is that we lower systolic blood pressure. So let's start with the FINE-ART program. So you know that very well, all the program of trials done on finerenone. How many of those patients have CKM? 90%. At least two or three components. Only 10% had only one component of CKM, with the most represented being diabetes and chronic kidney disease. And it is not only about being highly prevalent. This is a study from the NANESS survey in the US, so 11,607 US adults. And while 26% of them had at least one CKM component, you can see that the more component of chronic kidney metabolic syndrome they had, the more it was likely that the severity of the individual component was higher. Having both, you can see on the left, having both cardiovascular, kidney, and metabolic condition means not only having atherosclerotic cardiovascular disease or heart failure, mean very often to have both of them. And the same was true for CKD. When we take a look at observational studies, we can see that regarding the prevalence of CKM, the majority of CKM patients are patients with type 2 or type 1 CKM. I remember you that type 0 CKM is that not having any pathology, not even risk factor, so it is very, very healthy people, while stage 3 and 4 are patients with already established cardiovascular disease. So, of course, they are fewer than patients at risk of having a cardiovascular disease. Now, you will hear a lot from the next presentation of novel treatment for cardiokidney metabolic disease. So I like to shift a little bit the focus of the last part of this presentation on what we already have that we are using to treat our patient for other illness that may have an effect on cardiokidney metabolic pathway. So let's start with obesity. We know very well that the principal component of obesity is data intake. So for sure, being on a diet and having an active lifestyle are the main component to lower weights. We had some treatments earlier, like the sibutramine. However, the SCOUT trial almost killed the drug due to a higher risk of non-fatal MI and non-fatal stroke, despite a very good reduction in weight. And orlistat is actually no cardiovascular outcome trial. You will hear a lot from GLP-1 receptor agonists, SGLT2 inhibitors, but metformin is a treatment that we often give to patients for metabolic syndrome, and in meta-analysis is associated with a 1 kilogram weight loss after 1 year. So it's not great, it's 1 kilogram, but it's better than nothing, and it's a treatment that we often already use for different indication. What about hypertriglyceridemia? We know very well from the VITAL study patient in primary prevention, that receiving entry-PUFA was associated with a lower risk of cardiovascular events. However, does hypertriglyceridemia, or better, entry-PUFA, have an effect on chronic kidney disease? This is a meta-analysis published on BMJ. Those are 19 observational studies, so we're talking about association here, not causation. However, those are 19 observational studies showing a small but significant relative risk reduction of 0.92 for incident CKD among patients receiving entry-PUFA. Entry-PUFA always have this very small but significant effect also in trial, for example, in heart failure, if you think about the GCHF. So we kind of expected that. What about arterial hypertension? We know very well of the treatment we do for arterial hypertension, but SGLT2 inhibitors, they have an effect on arterial hypertension. They consistently lowered arterial hypertension. Those are a result from the Credence trial. But what about GLP-1 receptor agonist? We actually performed a meta-analysis on this, and we showed that receiving a GLP-1 receptor agonist was associated with a 3 millimeters of mercury reduction in systolic blood pressure and 1 in diastolic blood pressure. We found a very high heterogeneity, and we explained this with weight loss. So it is unlikely that there is a real effect of GLP-1 receptor agonists on blood pressure, but is almost completely mediated by weight loss. But still, we are talking about 3 to 5 millimeters of mercury reduction in systolic blood pressure, something that is usually achieved in the trials focusing on blood pressure reduction. What about renal denervation? Another treatment that we usually do for patients with very resistant arterial hypertension. And renal denervation, while useful to actually lower blood pressure, is a treatment that usually raises eyebrows regarding kidney safety. So I would like to present you that when meta-analysis of trial on renal denervation were performed, we found no significant association between undergoing renal denervation and worsening renal function. Regarding metabolic syndrome and diabetes, we know very well that metformin is very good, as well as physical activity and lifestyle, to prevent new onset diabetes. But again, metformin, should we use them when eGFR goes below 30? We have no doubt on that. This is a target trial emulation study done in a Scottish court. They took patients with diabetes, so we're talking about patients with established diabetes here. And the exposure was withdrawing or not metformin after a first event of eGFR under 30. The result was that actually withdrawing metformin was associated with a 26% higher risk of 3-year mortality. Again, observational studies, well analyzed, but still an observational study. What about new onset diabetes with ARNI and RASI? We know very well from randomized controlled trial that treatment with ARNI as well as treatment with RASI is associated with a lower incidence of new onset diabetes. Beta blocker seems to be associated with a higher incidence of new onset diabetes, however, with a very high heterogeneity, with atenolol seeming to be the one mostly associated with new onset diabetes, while other beta blockers seem to have a neutral effect. And lastly, the use of ARNI on liver function tests. You can see that in the PARADIGM-HF trial, patient randomized to sacubitril valsartan versus enalapril had a lower AST, ALT, total bilirubin, and alkaline phosphatase by the end of the trial. You'll hear a lot next about this, and I'm closing up. Thank you.
Thank you, Christian. Thank you for this very complete and nice overview. First of all, before introducing the next speaker, I wish you a good afternoon. And I would like to thank Gianluigi for arranging again this important appointment in Stockholm, which is the city that has adopted both of us. So I think now it's a pleasure for me to invite Dr. Beacom Botsgood from the US. She will talk about mineral corticoid receptor and all the new target for treating cardiorenal metabolic disease. Please.
Thank you. I think that introduction was so fitting. Gianluigi gathers an incredible crowd over here. It truly is a pleasure to come and present. The topic I have is a very hot topic. The ALDO antagonism is gaining more importance, both for the heart failure as well as the whole cardio-kidney metabolic. In the next 10 minutes, the concepts I would like to emphasize are: the pathophysiology is now shared across all organs. organs, we first recognize the maladaptive effect on hyperexcessive aldosterone expression in terms of the cardiovascular adverse outcomes, and the pathophysiology implicated both saltwater retention as well as maladaptive fibrosis, inflammation, all of which actually play a role in all organs. In the heart failure venue, we knew that these were critical both for systolic as well as preserved EF heart failure patients. But now recognizing that these are shared mechanisms in kidney and heart, but also other organs. Keep in mind, the adverse outcomes are not solely for the heart in terms of the pump, but also arrhythmia, as well as maladaptive remodeling of the heart. In terms of the vasculature, there is evidence of course, hypertension, but also stroke. And for the kidney, we know the progression of kidney disease can be attributed to excessive aldo, as well as elevated UACR. So in the context of this continuum, this actually probably is one of the mechanisms by which at the cellular level, we will see an importance of differentiation of agents and how they act. And currently, the framework of receptor antagonism is with non-steroidal versus steroidal, the good old spironolactone, eplerenone, versus a non-steroidal, which currently has the robust data from finerenone. The non-steroidal MRAs have more specificity for the receptor, shorter half-life, lesser metabolites, and a balanced distribution in the heart as well as the kidney. And we do have comparative data. So I'm going to first start with what do we know in terms of the CKD. With the steroidal MRA, unfortunately, we don't have that much data demonstrating prevention of progression of kidney disease. These are the two studies that has been carried out with steroidal MRA in CKD, both of which actually resulted in no benefit, and if anything, a signal for harm nominally in the first one, with an increased hazard ratio with spironolactone in individuals with CKD 3B and above. And that's the framework of what we had in the past regarding MRAs in CKD. The concept, though, is people may look at this saying, we just don't have data, or there hadn't been any studies carried out long enough. Majority of the patients in these studies stopped the steroidal MRA at 6 months due to the hyperkalemia and intolerance. The data that we have with a non-steroidal MRA is quite robust, especially starting from the kidney perspective, diabetic CKD or DKD, demonstrating both prevention of progression of kidney disease as well as cardiovascular outcomes in patients with diabetes and CKD. This actually has been shown in a pooled analysis of the two trials, Fidelio and Figaro, in the Fidelity pooled analysis, demonstrating a significant reduction in worsening of kidney function that eventually resulted in incorporation of non-steroidal MRA in the guidelines for diabetic CKD, in a variety of guidelines. And we have now, since these guidelines incorporation, have now evidence from a newer study, confidence trial, looking at co-initiation of non-steroidal MRA and SGLT2 inhibition, demonstrating synergistic additive effect in reduction in UACR, thus more benefit for the patients that are high risk for CKD. For prevention of heart failure, we don't have any data or large-scale data that steroidal MRA, i.e. spironolactone and eplerenone, prevents development of heart failure. We have post-MI data when they have heart failure that they prevent progression of heart failure when their heart failure is present. But for stage A, individuals with risk factors, or stage B, asymptomatic LV functional or structural abnormality, we don't have data with spironolactone or eplerenone that it prevents progression of heart failure. Whereas with non-steroidal MRA, we do have data both from the Figaro Fidelio combined pooled analysis and Fidelity which showed a very strong signal for prevention of heart failure, both by prevention of heart failure hospitalization, the first heart failure hospitalization events, as well as incident development of heart failure. And therefore, in diabetes with risk factors such as CKD, heart failure prevention has been incorporated in the guidelines as an indication for non-steroidal MRA. Individuals with type 2 diabetes and CKD, non-steroidal MRA is now recommended to prevent heart failure. And in terms of treatment of heart failure, yes, we do have the data with steroidal MRA, very robust, not only reduction in heart failure hospitalization and cardiovascular death, but all-cause death. And this is a differentiator, the magnitude of benefit and the concordance of benefit across all endpoints, starting with cardiovascular death and heart failure hospitalization to all-cause mortality and heart failure hospitalization with steroidal MRA is quite robust. Do we have data with non-steroidal MRA? Not yet. We currently don't have trial data demonstrating efficacy in this domain with non-steroidal MRA, but they're being conducted. Steroidal MRA is one of the foundational therapies, one of the 4 classes that are indicated in heart failure with reduced EF. In PEF, we don't have that strong data with steroidal MRA. We do have a trial, TOPCAT trial, that unfortunately did not achieve significance in the primary endpoint. In the overall population, there was heterogeneity. In the Americas population, there was benefit. Those were the individuals who were ascertained to have heart failure. Some of the populations that were recruited from some other geographies, unfortunately, didn't have evidence of heart failure with preserved EF and unfortunately failed to demonstrate any efficacy. In the aftermath of TOPCAT, okay, where we didn't see significance with steroidal MRA in HFpEF, US guidelines put all of the agents, as you see over there, including ARNI, MRA, and ARB, as 2B recommendations because majority of the benefit was in lower EF, and as the EF increased, there appeared to be a ceiling effect or a lesser magnitude of efficacy. And these were post-hoc analyses, and for that reason, we put it as an 2B recommendation. But since that time, we now have evidence from a large-scale randomized clinical trial, fine arts trial demonstrating significant cardiovascular death and heart failure hospitalization, majority of the benefit attributed to the reduction in heart failure hospitalizations, even in the subgroup of individuals who were already on SGLT2 inhibition, and demonstrating also metabolic signal of prevention of new onset diabetes in individuals not even treated with SGLT2 inhibition or treated with SGLT2 inhibition. In the aftermath of the fine arts trial, the whole community is trying to decide whether steroidal and non-steroidal MRA is a class effect or they're different. And if so, how will they be incorporated in the guidelines? Canadian guidelines combine them, but the US guidelines, which is being launched in terms of the writing committee as well as the ESC, next iteration is to be determined. Most likely will be informed with the concepts in the following sense. The fine arts as well as the TOPCAT, the trial I told you that was non-significant, when looked at the Americas group have a signal. And when people do a meta-analysis of these populations shown in orange, show efficacy. But we also have other trials that are ongoing as highlighted with the yellow. SPIRIT trials, which will be with steroidal MRA in HFpEF, will be informing us whether the steroidal MRAs work in HFpEF. And then there is a large portfolio of trials being conducted with non-steroidal MRA in hospitalized heart failure with preserved as well as reduced EF patients, as well as individuals who are intolerant to steroidal MRA in the setting of HFrEF finality study. These will inform us. SPIRIT trials are going to come next, and I think overall will inform us. This is where the data is. Currently, we know that MRA works in HFrEF, where we don't have the data with non-steroidal MRA. And non-steroidal MRA works in HFpEF. And then in diabetic CKD, non-steroidal MRA has the largest evidence of benefit. And we have a variety of newer studies being conducted either with non-steroidal MRAs as well as aldosynthetase inhibitors that are in the both HFpEF as well as heart failure prevention. And it's an era of combined therapies. As we heard from Christian, GLP-1 RA is coming into the CKM world, as well as a variety of other medications. And I think we're going to be looking at combined therapies. We did see from the confidence trial of the benefit or the synergistic effect of combining SGLT2 inhibition with non-steroidal. This is an interesting study looking at the estimation of a lifetime benefit from combined therapies in individuals with type 2 diabetes and albuminuria. When you add therapies, as you can see, the benefit or the permutations of the additive effects of therapy. So in summary, steroidal MRAs are effective in HFrEF. Role in HFpEF less clear, pending 2 trials, which will inform us. Steroidal MRA have limited evidence of benefit in CKD, maybe potential harm. No evidence of metabolic benefit in terms of new onset diabetes or hemoglobin A1C profile. If anything, some studies implying adverse outcomes with steroidal MRA. Non-steroidal MRA improves outcomes in patients with HFpEF. Ongoing trial with non-steroidal MRA in HFrEF that is intolerant to steroidal MRA. And yes, it improves outcomes in diabetic CKD. And there are a large portfolio of studies being conducted with non-steroidal MRA, as well as MR modulators and ASIs in the management of cardiac-kidney metabolic, ranging from prevention and treatment of heart failure to cardiovascular disease MACE endpoints and CKD. Thank you.
Thank you, Beacon. We're going to take questions at the end. And while you hook up Javed online, notice how we're moving in heart failure from neurohormonal approaches, catecholamines and renin-angiotensin, to metabolic fibrosis and inflammation. And the 3 drugs in this session are really a new paradigm. They're targeting not neurohormonal syndrome, but metabolic fibrosis and inflammation syndrome. So Javed on SGLT2 inhibitors and shortly thereafter, Mark on GLP-1s.
Hi, Lars. Can you hear me?
Yes, very well.
Perfect. Well, again, I appreciate the opportunity to present, and my apologies that I'm not there in person. My disclosures are at the bottom. Of all the 3 talks, I think I have the easiest target, not because the physiology is any more beneficial with SGLT2 inhibitor, but because the data gaps are more mature and have been filled with more trials, whereas with other therapies, there are more trials going on, and we will learn a whole lot more on an ongoing basis. So just a reminder that it was only a decade ago that the treatment of diabetes used to be only management of hemoglobin A1C and other cardiovascular risk factors like smoking and lipids, but not specifically targeted in terms of long-term outcomes for diabetes per se, till, as we all know, that EMPA-REG outcomes trial came out. It showed for the first time that you can actually improve cardiovascular mortality in patients with type 2 diabetes. You can improve macrovascular outcomes, including MACE outcomes, and that it has started shifting the dialogue of not only hemoglobin A1C or glucose control, but actually improving patients' outcomes. But what is more relevant to our talk today are the 2 relatively, in retrospect, not surprising, but at the time, interesting findings. One is on the right bottom, the section D, which is heart failure hospitalization. This was an exploratory endpoint. This was not even hypothesized or in the part of the MACE, but there was a very substantial improvement in heart failure outcomes. And then the second was very substantial improvement in kidney outcomes in these patients as well. So that's where the dialogue got started, whether these drugs are cardiorenal risk-modifying drugs. If they are, based on what we know from pharmacodynamic studies and their impact on cardiorenal physiology, Does it even have to do anything with diabetes? That maybe both patients with and without diabetes will also benefit. But remember, at that time, there were also concerns whether this is simply a chance finding. So in the interest of time, I won't be able to go over comprehensively all the data, but at least the heart failure and the kidney benefit was shown over and over again with all sorts of SGLT2 inhibitors in various different populations. The cardiovascular mortality, EMPA-REC kind of stands out, and we can discuss what exactly does that mean. But the heart failure and the composite kidney, there are only numerical differences, maybe related to baseline patient population, but pretty consistent 25 to 35% relative risk reduction across all these trials. In the meantime, as Dr. Bhaskar has also mentioned, our thought process has also evolved about these cardiometabolic renal interactions, that these are not just linear reactions that, oh, if you have heart failure, you have poor cardiac output or congestion, so you develop kidney dysfunction, or if you have kidney dysfunction, you have sodium and fluid retention, hypertension, and you have cardiac dysfunction. That actually both, and so diabetes and perhaps liver disease and all of these things develop because although these direct linear relationships are true, the other issue is this underlying sort of the milieu in which the body is living with inflammation and oxidative stress and endothelial dysfunction and adiposity and insulin resistance that simultaneously puts people at risk for all of these things. If this paradigm is true, then there are some bad news and a good news. The bad news is that this is the same paradigm that leads to development of disease and progression of disease. The more of these diseases you have, the worse the prognosis. And if you have one disease, the likelihood is that subclinically other disease has already started and will continue to progress over time. The good news, however, is that if this paradigm is true, then you might give the treatment of, with one of these agents for disease X or disease Y, but you will get benefit for multiple organ system, and you will have the same therapies reflecting prevention of disease, and if you have the disease, progression of the disease, and this is exactly what we are seeing. So based on all this, there were large heart failure with reduced ejection fraction trials were done, but they were not diabetes focused, regardless whether you have diabetes or not. Both trials, baseline medical therapy was very good, led to substantial reduction in cardiovascular death or heart failure hospitalization. And the hypothesis was true that with or without diabetes made no difference, you had the same benefit. This is not to say that these are only cardiorenal metabolic agents, that these are not diabetes agents. Of course, they are great diabetes agents as well, but in addition to the cardiorenal risk modification is irrespective of diabetes. This was followed by 2 heart failure with preserved ejection fraction. Remember, now we have data with finerenone and more data coming out with GLP-1, but at that time, there was not a single therapy that had conclusively proven to be of benefit in HFpEF till these trials came out. Again, consistent benefit, and now we have therapy that works across the spectrum of ejection fraction, and indeed, even within the PEF, whether you had mildly reduced 40 to 50, 50 to 60, or greater than 60, no heterogeneity, the benefit was seen across the spectrum. Again, in the interest of time, I won't be able to look at all the kidney trials. There are data with multiple agents. I'll just pick one example, EMPA kidney, with or without diabetes, the broadest population of CKD patients that were studied in this with low degrees of albuminuria as well, had dual endpoint, and both the endpoints, the dual endpoints were positive, kidney disease progression or cardiovascular outcomes as well. And keeping this theme of prevention, also reduction in the heart failure risk as well with SGLT2 inhibitor. Again, we have seen similar data with dapagliflozin and other SGLT2 inhibitors as well. Again, we have seen that in heart failure over and over again, that if a therapy works, it works irrespective of the baseline medical therapy. And in these secondary analyses, whether somebody is on a GLP-1 receptor agonist or not did not matter. You were seeing the benefit. So with these overlapping pathophysiologies and overlapping epidemiologies of type 2 diabetes, CKD, cardiovascular disease, we know that now the American Heart Association has come up with this presidential advisory about the CKM syndrome with various different stages of CKM. But the good thing is that these therapies can affect across the spectrum. This is a really cumbersome slide that we put together. I won't go into the detail, but we did a very detailed meta-analysis of what is the outcome benefit if you have only one disease or two or three or various different combinations of two or all three. I mean, the bottom line is no matter how you slice and dice the data, you get benefit for multi-organ system. Dr. Boscott already showed you the data that combination therapy improves the outcome further. Right now, the big issue is not that we lack any data, it's the implementation gap that these therapies are picked up very, very slowly, especially in our highest risk patients because of the worry of side effect. These sicker patients have the least therapy given because the sicker patients who have the worst outcomes have the phenotype of potassium and creatinine and all of those things that we concern about blood pressure, that these therapies are not given. But in that sense, the SGLT2 inhibitor stands out because not only is there evidence gap, but tolerability gap for some of the other agents. SGLT2 inhibitor have sort of the most wide data in terms of low GFR going all the way down to 20, but in terms of tolerability as well, that these cardiorenal metabolic patients, dizziness, blood pressure, sodium, potassium, atrial fibrillation, creatinine, none of those things matter. They are very well tolerated. And indeed, we have many, many guidelines in primary care, in cardiology, in prevention, in heart failure, in diabetes, and in CKD that uniformly recommend these therapies. Thank you very much.
Okay, moving on. It is a pleasure to introduce Professor Mark Pitre on the use of GLP-1 receptor agonists in CKM.
So thank you very much. It's a pleasure to be here. I have to say Stockholm is a fantastic place. I came here 2 years ago for this meeting and dragged my wife and friends along and had a brilliant weekend with the Vasa Museum and great restaurants recommended by Camilla. So just really fantastic. So I'm afraid it's a short visit this time, but what a fantastic city. So I'll be controversial, I think, in the commentary rather than right now. In fact, I'll be controversial right now. Why not? So who in their day-to-day clinics with their colleagues, their cardiologists, their kidney colleagues, talk about this patient has CKM in the cath lab or the EP lab? Put your hands up if you say CKM in day-to-day clinical practice. Okay, one. Okay, who does it? Who talks about myocardial infarction, stroke, heart failure, kidney disease? Can anybody put their hand up at all? Yeah, they can. Excellent. Okay. So I think we should discuss that because for me and my colleagues, I've never heard of CKM. So we need to be careful about keeping the clinical community alongside the academic community. That's a really important point. Okay, I've got 10 minutes to talk about GLP-1 RAs across all of these different disease areas, which is impossible. So I'm going to talk in Scottish far too quickly so nobody can understand a word I'm saying. So I thought pressing the forward button would make it go forward. There you go. Excellent. Okay, here you go. So basically, all of you who are sitting here today, some of my colleagues think that weight management drugs are for somebody else. They're futuristic. They're something different. There are now 200 of these drugs in development. So this is going to become day-to-day life for all of us, particularly the younger people in the audience. These are cardiology drugs and they're going nowhere. They're rapidly expanding with tons of trials. So this is really exciting. And it's not just GLP-1 receptor agonists, as the title of the talk said. There's lots of other different mechanisms here, some of which I'll touch upon, but some of which I won't. But there are certainly some other agents that are fascinating because of potential benefits even above GLP-1 RAs. So Javed's given you the data about SGLT2 inhibitors and diabetes. So remember, these trials, these diabetes cardiovascular outcome trials were done to make sure we weren't killing people. So the diabetes drugs looked like bad things, giving people heart failure. These are safety trials. But just remember, looking at all these trials together, they're certainly good for cardiovascular endpoints. So when you're in a diabetes clinic, you would be thinking about using a drug with cardiovascular benefits. Again, Javas said people used to think of these as diabetes drugs. You see these benefits in people with high and low HbA1cs, but also with and without obesity. And remember that. So these are called weight management drugs or obesity drugs. In these trials, we saw benefit in people with and without obesity. So let's not think of these as weight management drugs or obesity drugs. Some of these trials are really important for heart failure fanatics like us. Some of the trials with the biggest benefits in terms of heart failure hospitalization reduction were with drugs that hardly did anything in terms of HbA1c reduction or weight reduction. So there's one here called Harmony Outcomes, which had a 29% relative risk reduction in heart failure that hardly affected HbA1c or weight. It was actually binned by the company because it didn't work, in inverted commas. So please don't think of these as diabetes drugs or weight management drugs. So I'm now going to talk about contemporary data, no old data, just contemporary data from now on in this updates meeting. So the first thing I was going to mention was SOUL. So SOUL was with oral semaglutide. Most of these drugs are injectables, and this is the first big outcome trials looking at oral semaglutide. So almost 10,000 people with diabetes and cardiovascular disease or chronic kidney disease with a conventional MACE endpoint. And of course, with oral semaglutide, we did see a reduction, not huge reduction, but 14% reduction in the conventional MACE endpoint. And there was a signal of possible heart failure benefit in SOUL. So this week, actually, we're going to see the formal publication of the SURPASS CVOT. So this is a fascinating trial. So the detail of this will be known about this week. We don't have the detail yet. We've all seen presentations. But the headline is that our tirzepatide was non-inferior to the active comparator to dulaglutide. So tirzepatide is a GLP-1 receptor agonist married to a GIP agonist against a GLP-1 receptor agonist by itself. So this is really interesting because normally we're getting GLP-1s against placebo. This is now active comparator. So more of these trials will be coming our way in lots of different disease areas. So fascinating. The difference between the two arms wasn't massive in terms of MACE, so 8%, but there was a 60% lower all-cause mortality. But this week, you can spend your Christmas holidays reading the New England Journal paper and look at the fine detail. So rapidly moving on to the kidneys, which we talked about are fascinating and important organs, apparently. So GLP-1s in kidney disease. So the poster child here is the FLOW trial. For some reason, they chose a primary endpoint of kidney things. I'm not quite sure why that is. But anyway, it was semaglutide 1.0 milligrams against placebo, a large trial for the kidney doctors, 3,500 people, diabetes and CKD. And again, looking at the important endpoints, no offense, MACE was reduced by 18%, and you see these other benefits, particularly the mortality signals being impressive. If you dig around enough, you can see some heart failure outcomes, and these go in the right direction, although they're not large numbers of events and not huge treatment effects. So I've already rapidly covered diabetes and obesity, diabetes and CKD. So what about obesity? So obesity is really where a lot of the action is going on. All of these hundreds of drugs going through all of these fascinating trials. We can discuss these issues in the discussion, but how much weight loss is right? What do you lose when you lose weight? How quickly do you titrate the drugs? What do you do maintenance-wise? There's lots of different things about your diet and exercise while you're on these drugs, oral, subcutaneous. So millions of things to talk about here. I just thought I would choose this trial was published 2 days ago, so I thought I would show this. This is retatrutide. So retatrutide is now a triple agonist, so GLP-1 receptor agonist, GIP agonist, and glucagon agonist. So you see these drugs getting slightly more complex. And this is a population with osteoarthritis and obesity, and this remarkable 29% reduction in body weight. So this area is fascinating. Literally every week, there's a new publication that comes out. So what about obesity and cardiovascular disease trials? So apologies for showing this. This is 2 years old. SELECT is the kind of massive trial, 17,500 people, obesity and cardiovascular disease, excluding diabetes. This is the 2.4 milligram weight loss dose of semaglutide, the GLP-1 receptor agonist, and time to MACE was the primary endpoint. So you all know this 20% reduction in the primary endpoint of MACE and a 21% reduction in heart failure event were heart failure people. So looking at the data here, this is not great data. The HFpEF here was investigator reported. So no baseline echoes, no baseline BNPs. Somebody just ticks a box saying HFpEF. So you see there's lots of patients, over 2,000, but not a lot of events. Event rates are very low. So it doesn't really tell us very much, but the hazard ratio is in the right direction. So that's encouraging, but certainly not conclusive from a heart failure treatment perspective. What about HFrEF patients in SELECT? Again, this is a tick box, no echo, no BNP, just a tick box. Hardly any events here, 71 events only, but a signal towards possible benefit with a hazard ratio of 0.79. So the next 4 slides are just to give you a flavor of what's coming your way. Lots more cardiovascular outcome trials. So here's another one, SURMOUNT MMO, tirzepatide against placebo, 15,000 patients. This is my Scottishness coming in, I get faster and faster. So REDEFINE, CagriSema, which is the Novo Nordisk, amylin, GLP-1 combination, 7,000 people, going down to BMIs of 25. TRIUMPH outcomes, this is the retatrutide, the triple agonist, 10,000 people with MACE as a primary endpoint. Synchronized CVOT, this is the Boehringer Ingelheim, survodutide, 5,500 people. So all of these trials are going to be published over the next 2 or 3 years. So again, fascinating area, rapidly moving, and you almost need an update meeting every week to keep track. So now I've done diabetes, CKD, obesity, now heart failure in 2 minutes. So what do we know? We've got some 2 small trials, one STEP-HFpEF and the other called SUMMIT. And these are STEP-HFpEF is semaglutide, SUMMIT is tirzepatide, looking at HFpEF. Both small trials, STEP-HFpEF was 1,400 patients, SUMMIT 700 patients. And basically, they didn't show very much, but they showed reduction in weight and improved health status. They did show some other interesting things, like directionally favorable clinical events. Were only 38 heart failure hospitalizations in each trial. So combine both trials, only 76 heart failure hospitalization. There was a reduction in NT-proBNP, which was good, and a reduction in CRP. But look at these treatment effects. So the hazard ratio 0.27. So if you believe that, a 73% reduction in heart failure, or a 56% reduction. But of course, we know in small trials, you see big treatment effects indeed validated in big trials. I just contrast that with the data which Bikram and Javid have shown you already. Tiny numbers of events in these trials against very large numbers of events in the previous trials. Death in these 2 trials, the 2 small trials, 20 deaths in total across the 2 trials. So these are inconclusive data. And in fact, in SUMMIT, they went the wrong direction. But again, tiny numbers, you're a fool to overinterpret small numbers. So now there's a race on to see what the best drug is for heart failure, oral, subcutaneous, weekly, monthly, GLP-1 by itself, or add on, whatever you want to add on. Luckily, not luckily, but we're absolutely thrilled to be doing this large definitive outcome trial with Amgen's maridebart cafraglutide. And again, you need a lesson in pronunciation when you look at these trials. This is a large trial, 5,000 people with a proper endpoint, cardiovascular death or heart failure event. We're looking for 850 primary events in this trial, simple HFpEF population. So these are the kind of trials we need across heart failure area to show whether or not these drugs are beneficial. There's one other trial about to be announced, but we can't talk about that quite yet. What about obesity drugs and HFrEF? So if every day I get telephone from people around the UK and around the world saying, can I use weight loss drugs and HFrEF? And people want to do it before AF ablation, transplant, whatever you want, or just to make them better. So what's the evidence for that? So there are 2 micro trials in this area. So live 240 patients and FIGHT 300 patients. So tiny trials. Live was Danish and had 1 death and 1 heart failure hospitalization. So you can't interpret that too much, I don't think. Neither of these trials are obese HFrEF populations, they're just HFrEF populations. And they're also not the weight loss dose of the drugs. FIGHT was the American trial. Again, very sick people. Everybody was within 2 weeks of hospitalization for heart failure, median ejection fraction 25%, 12% mortality in 6 months. And you can see the numbers of events there are pretty small. Deaths 19 against 16, hospitalization 63 against 50. So this is an unanswered question, but these trials make you a little bit anxious about these drugs and HFrEF, but certainly don't tell us the answer. So in the interest of time, I'm not going to tell you all the trials that are needing done, but you can imagine there's mechanistic studies needing done, outcome trials needing done. Just about everything needs clarified in HFpEF and in HFrEF. Also the rhythm issue as well. We see a slight increase in heart rate with these drugs. So looking at heart rate would be sensible. So lots of other trials, hospitalized people, non-obese people, people around the world with heart failure are very different. So we need to look at different treatment effects across different places. And of course, different adiposity measures. BMI is pretty bad as a measure of visceral adiposity. So we need to use different measures. Thank you very much.
Rafael?
Yeah, thank you, Mark. So we're open for questions from the floor or from the... Do you have a question or I can, yeah, please.
So Mark, very nicely done. The weight loss independent effects were seen in SELECT and FLOW, but in HFpEF, it looked like all the feel-good parameters were related to the magnitude of weight loss, i.e. most of the intermediate endpoints or 6-minute walk distance, health status was better the more the weight loss was. So do you think HFpEF, the difference in HFpEF and obesity as to what we attribute our symptoms to, were these trials really HFpEF trials, or what is HFpEF in obesity? And is there more to it?
I'll tell you the meaning of life as well, just to throw that in. No, I think these are all exactly the questions we should be asking ourselves. These 2 very, very small trials were basically only granted to us because we pestered the companies to do an outcomes trial. And everybody said that GLP-1 receptor agonist, put your heart rate up, we were going to kill people. So that was the whole narrative behind it. So we've small trials with functional endpoints. We can't tell very much. The answers to your questions, I'm not sure. In defense, we do have some indicators with those trials that maybe we do see a beneficial effect on heart failure. The BNP going down is interesting. We didn't expect to see that because as you get lighter, your BNP goes up. It was also very early we saw that. And the CRP reduction as well was very early as well. But what we need is definitive trials in all the populations I put up to tell us what's happening. We don't know, Bikram, and I've got the same questions as you do, but certainly there's lots of it is weight loss. We shouldn't be embarrassed about saying that. A lot of it is weight loss, but there probably is something else to it as well. But nobody knows the answer to that.
Cheryl?
Mark, I'm going to put you on the hot spot one more time. When we look about regulatory approval, STEP, HFpEF has been out for some time. Summit followed thereafter. Both were submitted to FDA, both pulled back, I think. I know it's rumors, not my country, I don't know.
They were rejected.
And I think one's being put back in, maybe after some more data or analysis, I'm not sure. Wondering what's going on in Europe. And then also wondering what the fine print is on SURPASS CVOT that we should be paying attention to.
Yeah, so the first thing is the regulatory situation. So they were submitted and they were not accepted. So that's public knowledge. I'm not breaking any confidences. That's what happened, which I agree with because we were thrilled with the direction of the clinical events. I mean, 38 events, 8 in one arm and 30 in the other arm in favor of the drug is very encouraging, but nobody in their right mind would say that was enough for clinical practice change or guideline change or any indication change. So I think that's appropriate. But Shelley, I'm not sure if you agree with that.
It's interesting because I am quite certain that the companies all went to the regulatory groups to find out what a good supported endpoint would be. I will say, the Canadian guidelines, Beacom alluded to them. They recently came out. I think I sent them to most of you in the room here. And we did a strong recommendation for MRAs as a class, moved it up from a lower recommendation to a higher. But we did recommend also GLP-1 RAs based on our meta-analysis. And that was even before Summit in terms of reduction in heart failure hospitalizations. So, it's interesting that the regulator, there's always a mismatch between regulator approval and guidelines. They don't seem to ever meet in the sweet spot.
So Shelley, I think I'm going to put you back in the hot spot again. So I looking at the meta-analysis that all of these trials, which I tried to show, are not HFpEF trials. They're people who are investigator-reported HFpEF. Their event rates are very, very low. They don't look like heart failure people. The number of patients is not very large. The event rate's low. The event numbers are low. So I would have rejected it too, to be honest.
Shelley, carry on if you have.
No. Just I thought you were going to.
So I think the Canadian guidelines we're here to be controversial. So I think they were charitable to the drug class. To be honest, for me, they did really, really robustly designed trials conducted with a very clear population with HFpEF. And again, Bikham's pointing out that maybe some of these people in the trials have debatable heart failure. In Summit, they had a mean BNP of 180. I think most people, if I had said to my colleagues in the corridor, I have a heart failure patient here, their BNP's 120, they would think that was surprising. I realize in North America there's a big obesity HFpEF phenotype and there's a big debate about that, but still, that's for me, a lot of the patients probably had borderline HFpEF and included by things like hemodynamic parameters, the validation of which is not very robust, to be honest, the exercise hemodynamic parameters.
I would say in Canada, our guideline process is a very, somewhat rigorous process in which the methodologists essentially tell you what the data is and they give you the wording for your recommendation. And there's not a lot of alteration that you can make from a clinician perspective.
So we've talked about 3 drug classes. With SGLT2, there's a no-brainer. With MRAs, there's a question that will be difficult to answer of steroidal versus non-steroidal versus ASIs, aldosterone synthase inhibitors coming. So that's a big open question. For GLPs, what is the open question? Why are we talking about this since they are indicated for obesity and are or will be approved and subsidized for obesity? Why are we digging into the heart failure aspect? Is it because we think it'll be more compelling to clinicians, even though the indication won't be expanded? Or is it because we're seeking an independent expansion label completely independent of BMI?
The first comment I have is we don't have the safety in HFrEF, do we? And the concept of you could give it to anybody and every walking individual, I think has not been answered. And in that context, we in JACC Heart Failure last year published a rather small and of course observational of what's happening to the ICD shocks. Similar to the signal that was seen in, FIGHT and LIVE and, this heart rate increase and AFib and non-sustained VT, all those I think will need to be answered in a large scale definitive trial that it is safe. Now, efficacy part of it is the MACE endpoints has been a consistent story in GLP-1 RAs, even in the diabetes trials. We've seen the MI and stroke go down. So the thrombotic events are going down. What's happening to the heart failure? And SELECT started this, FLOW also supported it. Without the MACE endpoints, the heart failure doesn't make it. Meaning, is this truly a heart failure beneficial? And back to your question, Lars, why do we care? So I'm going to start like safety is important. And then efficacy comes as a yes, the indications matter because I don't think we'll be able to afford giving it to the whole world population and then putting it in water. And the proximate indication is by which these agents get covered or paid for. And if it's for stroke, they cover it. If it's for MI, they cover it. Heart failure may make it more.
I think we've got to come back on that. So, Java, do you want to go first, or do you want me to go first back in the why do heart failure trials and GLP-1s?
Yeah, so I'll make a few comments, and I'll be a little bit of a purist, and I think that we are appropriately excited about incretin-based therapy, but also prematurely excited about these therapies, and I think we're extrapolating a little bit too much. I am equally excited, and if I were to be a betting person, I would bet probably every single chip I have that these trials are positive. However, that does not mean that we should just go ahead and give a recommendation for clinical use without the evidence from clinical trials. And here are some of the reasons. So one, in heart failure, we obviously have a history of things that improve biological markers, but in trials ended up having higher risk of mortality, hospitalization. In heart failure, we have examples where therapies made people feel great. Their symptoms got better, quality of life got better, but also at the same time increased mortality, hospitalization rate. So heart failure, you may or may not be able to take the lessons from other diseases. I actually don't know. I know that at this point, we are completely overruling that weight loss associated with worse outcomes or lower weight associated with worse outcomes in heart failure is epidemiologic paradox, and I get it. Having said that, is the degree of weight loss of no consequence in heart failure? I don't know. I don't know what we have learned from obesity. Losing 20%, 25%, I mean, at some point, is it detrimental? I have no idea. The lean mass loss is associated with not only skeletal or your liver mass, but it is also associated with reduction in LV mass. Is reduction in LV mass in patients with eccentric hypertrophy good or bad? I actually don't know. If you look at the SUMMIT trial, their mortality hazard was 1.25, going in the wrong direction, which again, I am 100% convinced is nothing. It's a nothing burger. It's a small numbers, lots of missing data and all that kind of stuff. Having said that, we just don't know. And I think that unless and until we do mortality, morbidity trials, this question will always be out there. And I think it's a little bit premature to jump the gun.
Yeah, I'm just going to add a bit, Lars. So it's a great question, though. So I don't know what the HFpEF trials, the results are going to be, whether they're going to be a tiny treatment effect or a massive treatment effect, and safety, as Bikram says, is vital. So I think we absolutely don't know the safety and efficacy of these drugs yet. That those two small trials, which are heart failure trials, have, pretty well populations, obesity, related to HFpEF, but very small numbers of events. And they just open up the possibility that they might be helpful. But again, we look at across all of our history as cardiologists doing trials in different disease areas, they're very informative. You get differing treatment effects and different safety in different populations. So for me, the life and fight are, I'm not dismissing them there. I'm just saying they're big holes here. But then where does that stop? Ejection fraction 35, 40, 45, 50, 55. We need to do a lot of trials, and we are going to do the trials, and we'll come back, and these trials will probably finish 2028, 2029, some of the first ones. So we'll have data soon to discuss. And let's remember this conversation. We think they're going to be home runs. I'm not sure they are. We're doing them really to find out what the benefits are.
And I'm going to add, heart failure is going to be critical as an endpoint for primary prevention, i.e., prevention of development of incident heart failure is a critical one that is actually identifiable and I think is a signal for longevity, maladaptive pathophysiological processes at the cellular level. Meaning what we're trying to abrogate here is oxidative stress, inflammation, fibrosis, which is part of aging and dying and maladaptive and organ damage in all diseases. So this is actually a pathophysiological entity, and we are trying to figure out, I would be very excited if this has got nothing to do with weight loss. And when given at smaller doses, that doesn't result in, let's say, the magnitude of weight loss it does in maybe less sicker populations or earlier populations to be put on board, despite all our horrible diet and so forth, is being protective for young individuals for the long term, for prevention of diseases across the board. It's an interesting concept. And I think in that context, heart failure is going to be the surrogate signal, meaning, you know, things going in the right direction when you prevent heart failure. And we're going to start with that for prevention.
If I may add one more comment, quickly one more comment, and that is, this also reminds me of this discussion. Look, I mean, I would be, clinically speaking, I'm completely on board. It's like, why do we keep doing these large trials and why can't we just extrapolate? The only problem is that we have a whole track record of sort of extrapolating and not being correct. Reminds me of the statin days that every single trial was positive, and when patients with CKD, it was trial the dialysis population, the same questions were being asked, that you're taking population which is enriched for cardiovascular events, why do you need the trial? And obviously it showed nothing. But a more cogent example would be that when NOACs and DOACs were coming out, and all the trials were positive in stroke and atrial fibrillation, in valvular disease, in prosthetic valves, this question was again raised, like, why do we need a trial? It's an anticoagulant, and that trial was stopped early for harm. So, I mean, these diseases differ differently, and I think we really need the data.
I would like to remind the faculty that the session is treating cardiorenal metabolic and not to be focused too much on heart failure. I understand that this is kind of but along this line, I mean, what do you think? And it's open to all of you. About the combination therapy of SGLT2 and GLP-1, incretin-based therapies, when you consider the wide spectrum of the cardio-kidney metabolic disease?
I think that for sure starting with SGLT2 inhibitor and GLP-1 receptor agonist will likely be the way to go, given that trials are positive for other pathologies. Like, for example, if we think about arterial hypertension, we for sure know that patients with obesity receiving GLP-1 receptor agonists have a lower blood pressure by the end of the trial. We have the same data on SGLT2 inhibitors. However, when we compare those treatments with other that are only reducing blood pressure, like calcium channel blockers, they also have an additional benefit on cardiovascular mortality and MI. So in the future, it is very likely that we may start with those. When we think of weight management and weight loss, there are also evidence pointing to SGLT2 inhibitors being associated with around 1.5 kilogram of weight loss by the end of the trial in the trials performed as of now. And the same is true for kidney outcomes for renal trials. So in the end, I find it very likely that they will become I will not say standard, but for sure very, very used for prevention. Not sure regarding specific pathologies, like for heart failure, for sure we need trials. And we have evidence for MI, so for secondary prevention, at least we have some evidence from GLP-1 receptor agonists, not yet for SGLT2 inhibitors.
So I love meetings like this because my lens is so different to others. So I want to say a couple of things. First thing is around the non-steroidal MRAs, and we mentioned the Alchemist trial. And Achieve as another trial of non-steroidal MRAs. We need to remember that they were in people who didn't have a diagnosis of heart failure, actually. So they were looking at reduction of heart failure and cardiovascular events in people enriched for poor cardiovascular outcomes, but they didn't have a diagnosis of heart failure at enrollment. So we just need to be really thoughtful that that doesn't mean to say that for people with heart failure syndrome, that we wouldn't necessarily treat them with non-steroidal with spironolactone just because the Alchemist or Achieve studies didn't show an outcome. I just want to be really clear on that, because actually I think for people on dialysis with heart failure, the data is not there that they wouldn't benefit, actually. And the second thing I would say is that we're still talking about these as weight loss medications, but from FLOW, that was not a weight loss mediated outcome. And so for me, you know, we've got to the point for people with living with type 2 diabetes and CKD that we've almost got to the point on GDMT that we have, this was talked about at the ASN at one of their, one of the state-of-the-art lectures, that we're getting to the point where we can cure CKD because we're bringing back the progression of CKD over time in line with an age-related decline if they're on all of their pillars of therapy, including a GLP-1 receptor agonist. And that's independent of weight loss. So the questions that I'm being asked is, at what point of BMI would you think it would be unsafe to start this drug? Because it isn't about their BMI or about their weight loss. It's about the preservation of their kidney function, actually. And I think we're going to start to see more data around the weight loss independent factors, and then we will just be looking at this in a very different way. So I just caution, you know, I accept that the language around heart failure is very important, but for people with CKD, the narrative is slightly more nuanced because it isn't about weight loss.
So if I may just quickly add one comment, that's a nuanced but a really important point that was made, because we spent about 5 years fighting that SGLT2 inhibitors are not diabetes drugs alone, right? So they are cardiorenal risk modifying drugs. But when you have the label of a diabetes drug, there's a lot of opportunities that are lost in the clinical practice. And I think just labeling them strongly only as obesity drugs have this connotation that people will, for a whole lot of reasons, may not want to treat or may not want to be treated for obesity, and you pigeonhole yourself in that. And thinking about these as cardiorenal risk modifying agents, just like we did for SGLT2 inhibitor, may be really important.
So Jared, you showed a fabulous slide about, so I don't think the data about SGLT2 inhibitors is controversial at all. And you showed a fabulous slide about that problem with implementation of the guidelines and that there is a huge implementation gap. And my worry would be, again, if I'm in clinic and I'm thinking I'm going to prescribe that Ozempic for the management of progression of kidney disease, and someone will say to me, well, that's a weight loss drug. And we have to think very carefully about that, because it is a problem with unpicking that further down the line, in the same way that SGLT2 inhibitors are diabetes drugs, and we're still unpicking that. So that's a fantastic point.
And again, this is a very US-centric comment. I don't know whether it's applicable to Europe or other regions of the world, but we are also coming at the heels of almost a decade of a very well-intentioned social trend, so that we don't shame overweight people, where there was this whole body positivity movement and all these things about healthy at all weights and whatnot, that there was actually a little bit systematic downplay about the issues related to obesity, and not everybody wants to be treated. So if you only label it obesity, there are still all of these other social connotations that go with it, but those are not the same for medical therapy.
Thank you very much. This has been a very, very interesting session about a very exciting and expanding area. And so thank you to all the contributors. And I think we're going to need some iron after this one. So it's going to be a session on iron HF starting in 20 minutes. But first, some coffee. Thank you very much.
Am I in your way?
By the side.
Let me just bring
Session 3.
Okay, warm welcome to the last session of today about iron deficiency and heart failure. Please enter all into room. So we have today world-leading experts here in the room, actually, and also online. So I'm sure this is going to be a really interesting session. And my name is Karin Korovic Cabrera from Karolinska Institute at Södersjukhuset. So we will start with Dr. Shelley Sybrot from Canada, who will summarize the evidence for now. Please.
Wonderful. Just noting that the timer says 20 minutes, not 10 right now. And it's very intimidating to be the first speaker when the authors of many of the papers I'm going to present are actually sitting at the table next to me as well. No doubt talking about iron right now as well. So here we go. 10 minutes to go here. And I also have to introduce the concept of iron deficiency because some of you may not be aware of the prevalence of iron deficiency within patients with heart failure. Iron, yes, it is an essential micronutrient. You can get absolute iron deficiency where your absorption is affected, but there's also functional iron deficiency as well that occurs in inflammation. And the standard definition, ferritin less than 100 or ferritin slightly higher with a TSAT of less than 20%. And I think there's a lot of discussion about this TSAT less than 20%. The prevalence of iron deficiency, even without anemia, is very high in patients with heart failure. And it is associated with a worsening New York Heart Association class, as well as reduced survival. In fact, iron deficiency is common regardless of ejection fraction. And you can see on this table of registries as low as an EF or mean EF of 26%, all the way up to a mean EF of 39%, very high prevalence of iron deficiency, both in chronic heart failure, maybe even slightly higher in acute decompensated heart failure. So it's very relevant to all of our practices. Now, for an example here is a recent state-of-the-art review, very interesting paper, which I had the privilege of handling as an AE at the European Heart Journal. And it came up with a very interesting figure on the mechanistic pathways of iron deficiency heart failure. Type 1 iron deficiency is that such that you can see the TSAT is very low. There's in fact a systemic depletion of iron. This results in progression of heart failure. In type 2, there is deconditioning and inflammation, which then targets skeletal muscle iron depletion, thus leading to worsening heart failure. And in type 3 iron deficiency, there is a very specific targeting of the cardiomyocyte, which leads to progression of heart failure. These are all very complex pathways. I think I need a cartoon to sort of visualize what all of this actually means. Here's the way I think of it, and we talk about targeted changes like mitochondrial dysfunction, apoptosis, results in the patient. What happens at the patient level? impaired exercise capacity, reduced work efficacy, impaired cognitive performance, as well as associations with increased morbidity and mortality. So now we roll on to the clinical trial evidence up to 2024. I will not go past 2024 because that's going to be coming up in Stefan's talk as well. So we start off with some functional studies with IV iron in patients with heart failure with reduced ejection fraction as well as mildly reduced ejection fraction. And what we saw in these clinical trials was an improvement in various definitions of functional status, improvements in biomarkers in those patients randomized to IV iron, as well as improvements in patient global assessment quality of life. So what kind of recommendations do these in fact translate into when you do these types of studies? Well, and this is again before two studies I'm going to show you next, AFFIRM and Ironman. This is where we started off with sort of a 2B, saying IV iron replacement might be reasonable to improve functional status and quality of life. These were short-term trials with a small number of patients. Let's go on to bigger, more robust clinical trials in patients with reduced ejection fraction and mildly reduced ejection fraction. The three on the left-hand side of this table include clinical trials with ferric carboxymaltose and Ironman enrolled patients to ferric dirosomaltose. You can see these studies include much larger patients than the functional trials. They're much longer in duration as well. And their primary endpoints aren't functional or biomarkers or quality of life. They're in fact, with the exception of CONFIRM-HF on the very left, these three are predominantly reductions in clinical events and heart failure hospitalizations. So the first two to come out were Ironman and AFFIRM, and then came HeartFit. So let's look at what happened with AFFIRM and Ironman, two bigger studies adequately powered for clinical events. I want you to look at the top portion of these Kaplan-Meier curves. Both of these trials just narrowly missed statistical significance is what they would say as they're being presented. There are risk reductions occurring, rate ratio 0.79 for AFFIRM AHF, and in Ironman, a risk reduction of 0.82, but confidence intervals crossing 1, and p-values were not significant. Then they do a COVID analysis as well, censored for COVID cases and pre-specified in Ironman as well, and they do hit statistical significance. And so this actually does, in part, impact future guidelines, this COVID analysis in both of these studies. Plus, they do a meta-analysis. If you don't get quite what you want, mix it up, put it in a meta-analysis and see where things land. And that's what happened here with both ferric carboxymaltose and Ironman, the other ferric dirosomaltose. And you can see that the use of IV iron in recurrent heart failure hospitalizations, cardiovascular mortality actually was in favor of giving IV iron. This then impacts future guidelines, this type of analysis. And you can see the Americans were a little behind still, but the Europeans in 2023 did make a class 1 recommendation for improvements in heart failure symptoms and quality of life, and a 2A for the reduction in heart failure hospitalization in those patients randomized to IV iron. Next comes the HeartFit trial. This is, again, a longer trial, large number of patients. This is the largest number of patients randomized to a ferric carboxymaltose trial. And I think just clinicians want to know, how often do I check it? The visits for this trial were every 3 months, and the dosing was every 6 months. So some practical guidance there for you. And the primary hierarchical endpoint, including all-cause mortality, heart failure hospitalizations, and 6-minute walk, did not meet the regulatory pre-specified target p-value of 0.01 with a win ratio of 1.10. So again, you'll see numerically there are improvements or reductions in death and heart failure hospitalizations and improvements in 6-minute walk test, but did not meet that statistical threshold for being clinically significant. A lot of talk about perhaps why that happened, and I've just circled what might be the main hint as to why HeartFID didn't meet its primary endpoint, and then perhaps is because it had the lowest percentage of patients with a TSAT less than 20%. You'll be hearing about FAIR-HF2 very shortly. But again, if you don't quite hit your primary endpoint, what do? You do a meta-analysis and have a look at the overall benefit of a therapy in a patient population. And you can see here the AFFIRM, CONFIRM, and HeartFID, all which used ferric carboxymaltose, showed a significant reduction in the rate of cardiovascular and heart failure hospitalization, but did not reduce mortality rates. So I think what we're seeing is an evolution of heart failure guidelines. I will end. My second last slide is going to show you some good news here. Cardiologists are well ahead of nephrology in terms of recognizing the importance of iron deficiency alone versus iron deficiency anemia. Nephrologists wait for anemia to occur to treat iron deficiency or look for it in any way. Cardiologists were ahead of the game. We're starting to look for it on our first clinician visits or first patient visits in clinic. I know I'm screening for iron, TSAT, and ferritin regularly in my patient populations as well. And this meta-analysis was a call to action for the nephrology community to recognize iron deficiency because of the potential significant event reductions which could occur. They're looking for their randomized controlled trials with iron in their patient populations with CKD. And this is my final slide. The iCardio Alliance is the most contemporary heart failure guidelines, which have in fact incorporated the data that Professor Anker is going to show you here and recommending IV ferric carboxymaltose or ferric dirysomaltose in iron deficiency to improve symptoms as a strong recommendation and for reduction in heart failure hospitalization and cardiovascular death as a recommendation. You can get this on icardioalliance.org website or go to Global Cardiology. Thank you so much.
Thank you very much for this excellent summary and excellent on time on the second spot. I just want to mention also we have another chairperson online, is Professor Ashok Kumar joining us from India. And now we go to the next speaker, Professor Stefan Anker from Charité Berlin, world leading expert in this area and has led many landmark trials. So it's an honor to have you here. Please.
Yes, let me start by a funny remark. Whatever is the time and CO2 spent on coming here, I discussed with Gianluigi and said, why don't we make this a bit more efficient? So I speak longer. So per minute, it's less kind of whatever it is. And I'd say this already to the chairperson. We agreed on 15 to 16 minutes.
Okay.
Now, you see all these guidelines, and I show similar things that Shelley is saying for one or two cases, but make a completely different point. This guideline, when it came out in 23, ignored, although the data were already known to the community, the HeartFID kind of statements. It ignored the meta-analysis that was coming out at the ESC. Rather unfortunate that guidelines sometimes intentionally ignore things just because of deadlines. And by the way, if you think about the 2026 heart failure guideline of the ESC, it will ignore everything that is not coming out by the 31st of December this year in peer review. So if you publish something at the ACC, it will be ignored by the guidelines. Now, the guidelines were informed by these previous meta-analysis, very successful results. I'm not showing it because of this, but I'm showing it because of these dramatic reduction in event rates, heart failure hospitalization, cardiovascular death, 47%. This is the reason how we planned. This data was the FAIR-HF2 trial reason for kind of developing the program. We thought, okay, let's be half as good, and we planned for this. What we didn't think really good enough about is that this was data limited to 12 months follow-up, and you will understand in a second why this is important. Then, of course, the Ironman study came out, and with Tim Freedy, we did a Bayesian statistic analysis. In Bayesian statistics, the most important result is actually the prediction of the next study. And you will see a very wide confidence interval. And the HeartFit trial came in somewhere on the less than neutral, and that was predicted by the meta-analysis. Then we saw these TSAT interactions. And if you look in a second at the primary endpoints of the FAHF2 trial, you will understand that there was the thinking that this TSAT interaction really means maybe we should have a new definition of iron deficiency, ignoring anybody with increased ferritin and just focus on TSAT alone. And FAHF2 was the only trial ever done to actually test the idea that low TSAT, here also in this meta-analysis, shown to be strongly associated with the results of the treatment, could be beneficial. Now, Shelley mentioned TSAT levels being on the higher end. They were not on the higher end in the HeartFit trial, but on the very high end. Look, this is all the studies before HeartFit done, and not a single trial had an average TSAT of above 20. So what was HeartFit doing? The average was 24. I put it to you, by modern criteria, I wonder whether 1/3 of these patients didn't even have iron deficiency. I don't know what they did. I can assure you, these patients were totally different. So FAHF2 in comparison achieved what we wanted to achieve. The median of TSAT inclusion was 16.4. So in that sense, it was successful from what it wanted to do for the inclusion. HeartFit, you've seen, let's be very frank, even if you call this possibly kind of significant, not meeting the pre-specified p-value, but a win ratio of 1.1, and these events overall make for very little difference. This is the Kaplan-Meier curve for this study here. And tell me what you want, but this is close to nothing. But the reason is actually that the patients, Shelley said they got every 6 months they got a dosing, but they only got a dosing if they had an iron deficiency like at baseline. In other words, 80%, 90% never got a second dosing. The dose that they received was at the beginning, and then for 2 or 3 years, they were left alone in most cases. We tried to do this a little bit different in FAHF2, and we succeeded halfway, unfortunately not full way. The study was done in Germany, most patients, and was done second most patients in Poland, a few other European countries. A few people involved are here on the podium. And I can also tell you that this was government funded 2/3. 1/3 was company supported, where Vifor not only gave drug, but then also additional funds. Because as is common in publicly funded trials, they never plan for trials taking longer. They never plan for funds need to be bigger. And there's almost no trial in the world that comes up with the final result having the original budgets. That just doesn't exist, but governments don't think that way. So we had to get money from elsewhere because the COVID crisis came in the middle of this trial program in a very relevant way. We knew during the trial that many patients didn't get the iron in the second and the third year. We tried to push this as much as possible. We didn't know exactly how this was winning. So we thought maybe the whole idea of having these recurrent events that basically don't work if you stop the treatment. Only first events work with the first treatment. Recurrent events require recurrent treatment. But if you have a poor performance of recurrent treatment, you may need to do things differently. So you know that I'm a proponent of having multiple primary endpoints. We did this in the ReShape trial as well. So we did it here as well. And one of the primary endpoints was actually focusing on the patients with a TSAT less than 20. We were thinking that in these more vulnerable patients, we should have a particularly strong reaction. Let's see. And we were also thinking having recurrent heart failure hospitalizations, excluding death, that the death winning chance was the lowest. Therefore, we wanted to have one kind of additional endpoint excluding death. I can explain you later the Hochberg procedure, but it's a very valid approach. So we did this trial, the baseline characteristics, 70 years of age, men 2/3, but very well treated patients, hemoglobin 12.5 on average, ferritin 70 on average. As I said, the median was 16 for the TSAT, 18 for the mean values, symptomatic patients with systolic heart failure. Now, a very important point. Half and half allocated to treatment or placebo. And now comes the shock. Look at this. Completeness of follow-up, 12 months of the original, you might say 1,100 patients after 1 month. We had already lost 10%. Of the original 1,100 patients, 600 at the end of 12 months, 390 at the end of 2 years, 200 only at 3 years. And the average follow-up, therefore, was much shorter on treatment than we were thinking. It's a 1.5 year follow-up in the trial. We hadn't really thought this through. Had we limited the trial at 3 years, at 2 years, at 1 year of follow-up, I will show you in a second, the trial would have been positive. We didn't do that. So what we did is we basically report here on several primary endpoints, p-value of 0.038, because in a Hochberg procedure, all 3 p-values need to be below 0.05 to win, or 2 of the 3 need to be below 0.025, or 1 of them needs to be below 0.0167. So here, 21% reduction of event rates at 12 months. Very impressive result, 29% reduction, but technically not significant for the total follow-up time. 20% reduction of heart failure hospitalization recurrent at 12 months, 35% reduction of heart failure hospitalization. But the totality here, the very bit beyond 36 months, you don't actually see here, that made the trial neutral. And here's the third endpoint in the TSAT less than 20 subgroup. The most significant result was this neutral result. The TSAT less than 20 definition does not work better than the original guideline definition, so we can continue to use it. Subgroups make no difference. All of this, no difference at all. The trial confirms that exercise capacity and quality of life and patient global assessment also are better. So here's the real problem. This is the dose all the trials give in the first year. 1,500 to 2,000 milligram. Look at this. We achieved 900 in the second year, but remember, that was only less than 50% of the patients anyway that were in the trial and got treated, and 700 milligrams in the 20 or 30% of patients available in the third year. The other trials, much less. So we were better than the previous trials. We were nowhere near what we have in the first year. The reason is, of course, the way you rule the continuation of treatment without going into the details. You can be liberal, very restrictive, like HeartFit, or somewhere in between. Very different rules. We have no precise idea how to guide the treatment. My private opinion, we should be very liberal. So what if we had stopped after 1 year like all the other trials? Look here at the p-values, 0.005, 0.009, 0.01. The patient easily would have been in the New England Journal, very positive result. 2 years, ReShape-HF2, we restricted at 2 years, like every device trial is restricted. Significant, easy sell to the New England Journal. Now, had we stuck with the original primary endpoint, which was this one, the total first and recurrent heart failure hospitalization CV death, and do the restriction at any of the time points at 1 to 3 years, win. The problem is the loss of follow-up time. The teaching for your future trials is restrict your drug trials, particularly when you have an IV infusion and particularly when you see loss of follow-up of these patients. Time restrict the follow-up. It's totally okay to do so. It's done in all device trials. Do it also in your drug trials. Much better chance. A drug is supposed to be given. Now, you are not allowed to do an on-protocol analysis, but you are allowed to basically time restrict the follow-up. The meta-analysis that was consequently done, the primary paper of VHF was in JAMA. We basically now did a primary endpoint assessment of the original VHF2 assessment, recurrent heart failure hospitalization and CV death at 12 months and for the total available follow-up. We analyzed all trials in the same way. Ironman published exactly how it was analyzed, and all the other 5 trials where we had the databases, we did exactly match the analysis. So very simple result. Overall, total duration of follow-up with the original primary endpoint that everybody wanted, 19% reduction, significant result on 7,000 patients. If you're restricted to 1 year where we give the treatment, this is very successful when you give the treatment, 28% reduction. Everybody wants to see the recurrent heart failure hospitalization, 22 in total reduction, 31% in the first year. And if you look at death, you know this 13% number? In the previous session, you saw SGLT2 inhibitor. The meta-analysis of all SGLT2 inhibitors in heart failure has exactly 13% reduction in CV death in the first 12 months, 18%, all-cause mortality is even 20%. One real interesting finding in this Nature Medicine meta-analysis was the subgroup of women. Don't forget, women get benefits for symptoms and quality of life, but for events, they seem not to get benefit. We need to figure this out more. Let me conclude that the FHF2 trial in itself was very consistent in its narrow miss to the other trials, but the totality of data is showing us benefits from the meta-analysis. The 20% less than 20% TSAT definition is not better than the guideline definition. It doesn't work. The women subgroups, we don't know. And yes, there are global guidelines. Let's see what other guidelines next year and later come. Thank you so much.
Thank you so much for letting us behind the scenes and knowing some tips and tricks for future studies in this field. So now we have the next expert in the field. It's Professor Stefan von Healing from Göttingen. Please, Professor Healing.
Well, thank you very much. You've heard already a lot or quite a bit about iron deficiency in heart failure, and I will be covering HFpEF and iron deficiency. I will talk a little bit about the function of iron in humans, about our organ-specific iron regulation, of course, about the prevalence of iron deficiency and the treatment of iron deficiency in HFpEF. So very briefly about the functions. I think you've heard already a little bit about that. Well, iron actually has multiple functions, and that is probably one of the reasons why we do see a lot of benefit from the treatment, because mitochondria contain iron. Each of the enzymes of the respiratory chain, each single one of them contains iron and requires iron for proper functioning. This is true for skeletal muscle. This is also true for the myocardium, but also in the nervous system, neurotransmitter synthesis is iron dependent, or the production of thyroid hormones. We recently found that also bone mineral density seems to partly depend on iron, because one of the enzymes in the production or in the activation of vitamin D is iron dependent. The most important markers, of course, you've heard a lot about already, are ferritin, which is storage of iron, and transferrin saturation, which is the utilization of iron, with the most important enzyme or the most important protein to alter the uptake of iron being hepcidin. Hepcidin is an acute phase reactant produced in the liver, and it regulates ferroportin both in the gut but also in cells of the reticuloendothelial system. And with that, we have absolute and functional iron deficiency. Functional iron deficiency meaning that the iron is trapped inside the cells of the reticuloendothelial system. So organ-specific iron regulation, of course, we know about a little bit about that. We know there's a strong dependency of peak oxygen consumption and the volume density of mitochondria. The more mitochondria, the more exercise capability. And since mitochondria require iron, it is important that iron deficiency does play a role in this scenario. Now, why can iron treatment help in improving exercise capacity? This is because of the mitochondrial iron need, because what's happening here is that phosphocreatine is being shuttled outside the mitochondrium, and creatine then goes back without the phosphate group, and the phosphate is used for contraction. Now, we have seen that iron is dependent on the respiratory chain. So each of the enzymes of the respiratory chain requires iron. And one of the studies that was done by O.B. Okonko's group in London, they looked at MR spectroscopy and with which you can visualize the uptake of phosphocreatine and the shuttling of the phosphate group. Now, what they did is they treated patients with iron deficiency with iron, 21 patients versus placebo. And what they saw is that the phosphocreatine half-life was reduced. And this means that the shuttling of the phosphate group is becoming quicker. And this may be one of the explanations why patients can exercise better after treatment of iron deficiency. Now, coming to the HFpEF, the prevalence of iron deficiency has been examined quite a few times now. Of course, you know that iron deficiency is mostly in heart failure defined as a ferritin below 100 or a ferritin between 100 and 300 if at the same time the transferrin saturation is below 20%. Now, using these criteria, we have used the SICA-HF data that we collected as part of the European Framework 7 project, and we found about 190 symptomatic patients with HFpEF, that 111 of them had iron deficiency. This is 58% of patients. Now, data from the Swedish Heart Failure Registry also suggest quite a number of patients being iron deficient, both in HFrEF but also in HFpEF. If you look at the HFpEF patients here, you see that 60.8% of these patients had iron deficiency, and about 1/3 of these patients is non-anemic, 2/3 were anemic. So there's a high prevalence, it appears, in patients with HFpEF to be iron deficient. Some of them, about 2/3, are anemic, 1/3 being non-anemic. The need of iron to treat the iron deficiency in these patients, as you can see, is quite high. Approximately 55 or even more % of the patients required 1,000 milligrams of iron to replenish their iron stores. Now, to the treatment of iron deficiency in HFpEF, there's only one published trial so far, but several are ongoing. And I think many of you will know other trials that are currently being put together, and we sure will hear more in the panel discussion. However, the trials that have been performed with the last, which has been presented by Stefan Anker just in the previous talk, most of them, or all of them essentially, were either HFrEF or HFmrEF trials or both. So the trials that I could find on clinicaltrials.gov is the one, of course, that I will present to you in a second, which Stefan Anker and myself have done together, is a FAIR-HFpEF trial. Then I found the PREFER-HF trial, which is completed, marked as completed in clinicaltrials.gov. It was done in Spain. And there is one trial, IRONICA, that is currently being conducted in the US. I think it is important to look at the different primary endpoints because this will have an effect whether or not the drug will show an effect or not. We use the change in the 6-minute walk test distance at 24 weeks, the same as true for PREFER-HF. If you take IRONICA, they use the same endpoint, but at 12 weeks. The hemoglobin threshold is also making a difference because there is in PREFER-HF, for example, no thresholds or no margins for the hemoglobin. At least I couldn't find any. For the iron deficiency definition, the guideline criteria were used in our trial in FAIR-HFpEF. In PREFER-HF, it's the same. In IRONICA, they only use the transferrin saturation below 20%. Of course, IRONICA is also a trial that recruits patients with HFpEF and HFrEF. And the randomization is either ferric carboxymaltose or oral iron.
Finally, there are usually at least some NT-proBNP criteria. Ironica, I think this is an interesting point, uses a BMI-specific cutoff. In our FAIR-HFpEF trial, we had an inclusion criterion of a 6-minute walk test distance below 450 meters to be included in the trial. And this might also be important because there is some possibility to improve the 6-minute walk test distance because it needs to be decreased at baseline. So the FAIR-HFpEF trial, which was published in the European Heart Journal last year, recruited patients with an ejection fraction of 45% or higher. There were several inclusion criteria for the left atrium, so an enlarged left atrium or an E over E prime of a certain cutoff, so an increased E over E prime. All these were parameters that were necessary, raised natriuretic peptides, and a 6-minute walk test distance below 450 meters, as I mentioned before. Presence of iron deficiency, according to the criteria, patients were then randomized to receive either placebo or ferric carboxymaltose, and the primary endpoint was the 6-minute walk test distance change after 24 weeks. And as you can see, there was a significant increase in the 6-minute walk test distance after 24 weeks, with the highest value achieved after 32 weeks, and the change here was almost 49 meters. And this is something that is deemed clinically meaningful. We have recently published an editorial in JACC Heart Failure commenting on another paper in which we discuss the need for redefining or reframing iron deficiency in heart failure, and possibly, and I'm sure we will discuss that in a minute, a transferrin saturation below 20% is an easier criterion for everyday life to be used to identify patients with iron deficiency. So more than 50% of patients with heart failure have iron deficiency. It is well possible that in HFpEF the numbers are even higher. Current definition, I've mentioned before, ferritin below 100 or below 300 together with a transferrin saturation below 20%. The guidelines tell us that this is independent of the heart failure type, so it can be used for HFrEF, HFpEF, HFmrEF. There is no differentiation in the guideline. Using TSAT alone may help identifying patients in clinical need of IV iron treatment, and iron deficiency is an important comorbidity, but I think we still do not sufficiently understand how to best diagnose this. Thank you so much.
Thank you so much for summarizing the gaps in evidence so far. So for the next talk, I think we have online Professor John Cleland from University of Glasgow, also a key expert in this field of iron deficiency and heart failure. So let's see if we can get...
Can you hear me?
Yes, we hear you.
Yeah,
Please.
very good. So I'm sorry to miss you in Stockholm. Unfortunately, I wasn't able to travel, and I see we're running behind time, but I'm not sure I'll help you catch up. But let's have a go. So I've been asked to talk a little bit about what's next, and I have a list of things that might be what's next. Changing objectives, redefining iron deficiency. That's been discussed a lot already. I'll make my points. Meta-analysis, the use of oral iron, synergies between iron and other therapies that are in the heart failure portfolio, dose, and I might have a rather different view from Stefan Anker, that is, and also new trials, and I'll focus mainly on the new trials of HFrEF rather than HFpEF. So changing objectives. Just to remind everybody that there's been a remarkable success across the trials of IV iron in terms of improving symptoms and quality of life and exercise capacity. As Shelley's already noticed, there is a problem with the HeartFit study, and that many of us think that the majority of these patients didn't have iron deficiency, and we can't fix what's not broken. So pretty convincing, but should we be convinced by these improvements in symptoms, quality of life, and exercise capacity? And the answer is, I think that we can satisfy patients, and I think we can satisfy clinicians, and the trialists and the regulators perhaps need to think again. Well-being, I think, is the key target for patients with heart failure and their clinicians, and they have common sense. And the common sense is that if you're feeling better, this is usually associated with a better outcome. This is an analysis from an old study, COMET, comparing carvedilol and metoprolol, where we looked at a thing called patient journey. So this was looking at the loss of notional life years, either due to impaired quality of life or to mortality. And a couple of important things to see on this slide. First of all, you can see that there was very little loss of quality of life due to the number of days these patients spent in hospital. And hospitalization was counted the same as death, so you got no points for quality of life if you were in hospital. So despite this severe categorization of hospitalization, it had remarkably little impact on the patient's overall experience. Intensification of diuretic therapy, likewise, not a huge impact. The two big impacts were on well-being and mortality. The longer you're followed up, the bigger the importance of mortality. But in the first 1 to 2 years, it is almost all driven by well-being. And in the Ironman trial, just to take a slightly different angle, we looked at all-cause hospitalization, not just heart failure hospitalization. And there was a significant reduction in all-cause hospitalization, which was driven both by a reduction in cardiovascular and non-cardiovascular events. And interestingly, if you look at all of the events in this study, you can see that there are more hospitalizations due to infection, many of them respiratory infection, than are due to heart failure. In this study, we classified patients according to the primary reason for hospitalization, but also where something contributed as a secondary, and Stefan could turn his microphone off because I'm picking up some noise from him. So you can see that, and iron improved both of these outcomes, and I think it indicates that there is improved resilience amongst this population to whatever life throws at them, and reflects their improvement in well-being and symptoms. So redefining iron deficiency, well, back in 2016, we published this paper showing a strong relationship between hemoglobin, death. Each circle represents the quintile of distribution. You can see that serum iron, particularly strongly related to the prevalence of anemia. Very weak relationship to ferritin. But notice that in terms of mortality, it's the lower your iron, the lower your TSAT, the worse your outcome. But the lower your ferritin, the better your outcome. So you actually want to have a low ferritin. Patients with a ferritin less than 50 are going to do very well. So how should we redefine iron deficiency? Well, I think ferritin is a good marker of iron deficiency when it's less than 15, but this is hardly any patient with heart failure. And in heart failure, it's really a marker of inflammation rather than iron deficiency. And we should just stop measuring it for clinical purposes because I think it just confuses people. In terms of TSAT, it's highly correlated with serum iron, but there's a sting in the tail, which you'll come to. And there's some diurnal variation, just this caused by the diurnal variation in serum iron. But this is probably suppressed in patients with heart failure, so it's not such a big of great importance. There's an acute increase after oral supplements, indicating that indeed there is some oral absorption of iron. Oral iron is not nothing in patients with heart failure. TSAT is also inversely related to ferritin. So if you have a high ferritin, you'll have a low TSAT and vice versa. So if you have a very high ferritin and you have a low TSAT, your transferrin then is low, and you will actually have a ridiculously low serum iron. So think about that. And I think this is quite important. On the other hand, if you have a very normal serum ferritin, you'll have a high transferrin, and then it becomes quite difficult for iron to saturate the TSAT. So you may miss some cases of iron deficiency. But I think one of the great markers of iron deficiency is hemoglobin. And I think that substantial iron deficiency is really unlikely in the absence of anemia. You might have some mild defect in your iron markers, but if you looked at the whole body iron content, I think it would only be mildly reduced. I do think we have to look at the definition of anemia itself. The WHO definition of anemia may be too conservative, and maybe we should be moving it by about a gram per deciliter up for men and women. And that brings us to serum iron, which might be the best marker of iron deficiency, but we do need more data. This is an analysis, the IPD meta-analysis that was published back in 2023, and the Ironman ferric de-Rhizome maltose study. Just want to highlight that if you select the right patients, the impact of IV iron is larger than the effect of an SGLT2 inhibitor in HFrEF. So we're talking about large benefits for the right groups of patients. Notice in the IPD meta-analysis, if your TSAT was above 24%, you had an increase in events. And in fact, there's an increase in mortality once your TSAT reaches a certain level. And actually, I think that TSAT greater than 35%, regardless of what your ferritin is, you may increase mortality if you give the patient intravenous iron. And for that reason alone, I think that we have to have a TSAT less than 20% as an indicator for the need for intravenous iron. The other thing I'd like to point out are the purple blocks. These patients actually don't respond very well in terms of a rise in hemoglobin to an injection of intravenous iron, but they do respond very well in terms of clinical events. And if you want to see a mortality reduction, it's the people with a high ferritin and a low TSAT who might be profoundly iron deficient. These are the ones who really get the big benefit. This is some nice data from the HeartFit trial, where they've actually begun to unwrap serum iron. Serum iron turns out to be the best predictor of the outcome from intravenous iron. You can see that many of these patients had high serum irons, and they were harmed by giving more iron, whereas the patients with the low serum iron got the benefit. So there are two ways to improve the effect of a treatment. One is to avoid treating people who might be harmed from the treatment. The other one, of course, is to focus on the people who might benefit. So doing one or other of these would be very beneficial. You've heard a lot about meta-analysis, so I'm not going to repeat that in great detail, but just to remind you, we have these two types of meta-analysis: trial-level meta-analysis and individual patient data meta-analysis. Stefan has shown you the conundrum of the male-female sex difference in the trial-level meta-analysis. Notice this is not seen in the individual patient data meta-analysis. Admittedly, the individual patient data meta-analysis doesn't include FAIR-HF2 or the Ironman trial, but I suspect that it will show the same. Now, the advantage of the individual patient data meta-analysis is that it adjusts for other covariates, which the trial level meta-analysis can't do. And I suspect that the reason why women don't benefit so much as men is that it's something to do with etiology. And we don't understand why there should be a difference in outcome by etiology with intravenous iron, but I suspect this is the driver. And just notice that if you have a low TSAT, these are the patients who particularly benefit. It wasn't statistically significant interaction in the trial level meta-analysis, but you can see that there does seem to be quite a difference between 0.77 and 0.96 in terms of risk reduction. Notice it's the people with the high ferritins in the trial level meta-analysis who tend to get more benefit. What about oral iron? I think most patients with heart failure do absorb oral iron. We've got an increasing number of studies that show that. It certainly improves your iron indices, it increases your hemoglobin, probably improves your symptoms, and it might eventually do everything that intravenous iron does. But many patients won't take their oral iron for all sorts of reasons. And if the iron deficit is large, then you may never adequately correct that with oral iron. On the other hand, I think there are legitimate concerns about IV iron. If you get the definition of iron deficiency wrong, I think you can give the patient iron overload, and I think that can be toxic. And there's also problems that myocardial regulation of iron seems to be independent of how the body regulates iron. And there is the potential for myocardial iron overload if you give repetitive doses of intravenous iron. What about synergies? Well, IV iron corrects iron deficiency quickly and reliably. Many patients do remain anemic. There's an erythropoietic defect. These are usually the patients with the high ferritin, the inflammatory profile. Notice that IV iron reverses the increase in platelet count caused by iron deficiency. So iron deficiency is a prothrombotic state, and that can be corrected by IV iron. And that might reduce thromboembolic risk. We don't have clear evidence on that yet. In terms of SGLT2 inhibitors, they stimulate red cell production. That will initially exacerbate iron deficiency, but eventually they cause a fall in hepcidin, the agent that blocks the absorption of oral iron. And due to the worsening iron deficiency and the anti-inflammatory effect of SGLT2 inhibitors, oral iron absorption probably is increased. And this will also slowly release iron from ferritin and increase GI absorption. But it takes time. Erythropoietic stimulating agents, they certainly stimulate red cell production, but they may exacerbate iron deficiency and may increase thromboembolic risk. And then we have oral iron, which may slowly correct iron deficiency. How should we put these together? Well, I think if you've got iron deficiency anemia, you have a large iron deficit, you should definitely get IV iron along with your SGLT2 inhibitor. And if you have a poor response, these patients often have end-stage kidney disease, consider an erythropoietin stimulating agent. On the other hand, if you have iron deficiency without anemia, I think it's a smaller and less certain deficit. I think there may be room for oral iron here, but if there's a poor response, consider giving intravenous. In the clinical trials, at least in the Ironman trial, it was only about 30% of patients who needed a top-up dose of IV iron each year. So these patients are not needing an awful lot of iron. Stefan might say they were underdosed, but we can debate that. And there might be a role for prophylactic iron, depending on what the clinicians and the patient agree. In terms of dose, just to remind you that if you have a TSAT above 24%, you give IV iron, you're quite likely to increase the patient's cardiovascular mortality. I think that's the most important message from this lecture. These are the data from HeartFID, and you can see that many of these patients had, if given intravenous iron, had TSATs over 40%. And that is generally considered a marker of iron overload, hemochromatosis, and you might be wanting to reduce these patients' iron rather than increase them. So I think I feel that these patients, certainly in the first year in the HeartFID study, most of the patients were iron replete and many were iron overloaded. In terms of new trials, the one that many people are waiting for is the IVOFER HF trial. This is a trial of HFrEF in patients with anemia and iron deficiency, and it's comparing IV ferric carboxymaltose with one or more oral iron preparations. Focus mainly in terms of improving symptoms and quality of life. but also hoping to look at heart failure events. And there's about 500 patients randomized in this trial. And then the big one that we're waiting for is the ICONIC HF trial. It's just started this year, so it's probably only got a couple of hundred patients in it so far. But it is a fully fledged phase 3 randomized controlled trial. Aims to randomize around about 2,000 patients, taking a leaf out of Stefan's book, in that the follow-up is restricted to 1 year. But it will only be patients with the TSAT less than 20%. And I hope that we'll have no restriction on ferritin. So I'd be perfectly happy to put patients with a ferritin of 1,000 into this study. So that's my talk. Thank you very much.
Thank you very much. And we open the floor for discussion. We're a little bit short of time, but we have like 15 minutes for discussion. And maybe I will introduce Felix Lindberg as a discussant, if you want to have a question first. And then please, the audience, feel free to go to the mic.
If there is nobody from the floor, I might ask about, I think in clinical practice, what sort of happens in the best case of scenarios is that you get screened, and in an even better scenario, you get screened and you're iron deficient and you receive 1 dose. And if you're even luckier, you get a repeat dose if you have an iron need exceeding a 1 dose administration. But I think it's very rare that you get a dose repetition that approximates even the most restrictive of iron repletion strategies, so the hard fit basically. So my question is, you touched briefly, Professor Cleland, on the role of oral iron. Do you think that there is a role for a hybrid strategy where you repeat with IV and then keep repleted with oral?
I think so. I think that should be considered. We don't know how successful that hybrid strategy would be, so we should be hesitant about jumping to conclusions. But certainly, in a situation where there is a problem about delivering repeat IV iron, then I think that we do see an increasing number of studies showing that there is oral iron absorption in this population. I don't think it's enough to correct a serious iron deficit, so I don't think it is a substitute for intravenous iron in terms of correcting the initial problem. But in terms of prophylaxis of recurrent iron deficiency, I think there certainly could be a role. And yeah, we'd love to see some studies. I don't think they have to be outcome studies. I think they just have to be studies that demonstrate that you maintain correction of the iron indices. And of course, find out if it's acceptable to patients.
Sorry, but John, just briefly, that was exactly the HeartFit trial. They basically every year reassessed the official iron deficiency definition, and they basically found nobody needed iron because the official iron deficiency definition wasn't fulfilled. That's why they had so little iron application in the second and the third year, and the result is nothing then.
Well, I think this result was nothing because they didn't have iron deficiency in the first place.
Correct, but if you that then automatically means if you do an oral iron study and you want to persuade the world to use it, you do need to have outcomes. Just correction of iron deficiency means nothing.
I'm just going to add here,
Okay.
Felix up a great point about making sure we have systems of care and algorithms when we apply evidence-based therapy in clinic. We saw some data on implementation. It's best when there are nurses involved and multi-care teams. You have to develop an algorithm for the administration of this repetitively, monitoring treatment effect, and communicating back to the primary care physician as well that your patient has iron deficiency, figure out why, or you can try.
Thank you. So we have a couple of questions, please.
Fantastic panel and wonderful talks. Maybe we are on the wrong road. I mean, we are all basing our diagnosis of iron deficiency on circulating markers. I mean, binding capacity, ferritin levels. shouldn't we maybe look into tissue parameters? Is there a way actually to measure iron load directly in skeletal muscle in the myocardium? And is that potentially a way to better specify our patients in need?
Maybe there is, but actually, who cares? This treatment, when you use the definitions we have, improves exercise capacity, symptoms, patient global assessment of well-being. That's actually a good treatment. That's actually a good result. And John said that in the beginning. So the definition was developed. The definition was developed for improving exercise capacity and symptoms and quality of life.
And we'd have an even better outcome if we got rid of all those people with a ferritin below 100 who didn't have a TSAT less than 20.
John, maybe we can prove that point in the IPD meta-analysis, but
Yeah.
but maybe actually, if you take the lessons from FAHF2, we could have had a better result if we just had truly continued the treatment, which we didn't do.
Fortunately, a very high proportion had a TSAT less than 20.
But John, the iconic, it's not ironic trial, ironic or iconic HL?
Iconic. Ironic was Stefan von Haling's study. Iconic is the ferric maltose study.
Trial, I'm sorry, you two things you jumped too short. You're pushing for low serum iron, but you were not able to persuade all our lovely colleagues to adopt that, unfortunately, which would have been nice. And second, the trial is only 1 year. It will work, no question. I mean, it will get then, the whole trial is not done to prove very much except for getting a regulatory approval, and it will get a regulatory approval. But do we, after this trial, know better how to treat iron deficiency? No.
Yeah, please, Professor Rossana.
Giuseppe Rossano from London. I have a question and a comment. The question is, since we see iron declining in the storage, so liver, spleen, and muscles, well before we see anything in the blood, don't you think that we should try to, and we give iron supplementation to improve mostly exercise capacity and quality of life, don't you think you should be giving it to everyone up to a certain level of hemoglobin? That is the question. The comment is on oral iron. John, and we absorb at maximum 20% of the oral iron you give, and the maximum you can give is around 200 to 300 milligrams. Because increasing over the 200 milligrams, you get the GI effects that basically limit tolerability. So actually, the mean absorption is between, in the vast majority of people, is between 5 and 10 milligrams. So with large discontinuation rates due to GI problems, even in those people with that take low iron load. So at 3 months, there is a 40 to 50% discontinuation. So how do you think?
Well, I think I said that if you have anemia and you have a large iron deficit, then you should have intravenous iron. I don't think there's any doubt about that. Question is, if you don't have a large iron deficit, and of course, every single algorithm for giving intravenous iron depends on what hemoglobin you have, because they accept that hemoglobin is a marker of the magnitude of the iron deficit. So, and sucrosomial iron and some of the more newer irons have far better GI tolerability. So I think these large discontinuation rates, I think they're unproven. They are possibly scaremongering. So I think that there is room, I think, for considering a hybrid approach. I accept Stefan's point of view that is correction of the iron deficit sufficient evidence that the oral iron would improve morbidity and mortality? Well, it looks like we have several head-to-head comparisons. I suspect they're not going to be large enough to prove that that a real difference doesn't exist, but we'll see. And I think that hemoglobin is a good marker of iron deficiency. We shouldn't just see it as a consequence of iron deficiency. It is also a marker of iron deficiency. And I very much doubt that you have a large skeletal myoglobin deficit without a hemoglobin deficit. I think that would be weird.
I don't think that's scaremongering, because if you look at the EPAR of the all oral iron products of the European Medicines Agency, you see that reported. You see that reported also in many of the SPC of the oral irons. So I think that those are data that are out there in the public domain. And you may get up to a higher oral absorption with the IV iron formulation taken by mouth, given together with the vitamin C, but then you cannot give it for more than 5 days and you absorb more than or no more than 40 milligrams.
Well, that's what I'm saying. You can't correct a large deficit with oral iron.
Thank you
Well,
for
not
this very
quickly.
interesting discussion where we have just a few minutes. I would like to invite co-chair Kumar. Do you have some closing remarks?
Yeah, wonderful presentation, lots of insights. Just a question to Dr. Cleland. You mentioned that the role of ferritin is very limited. So do you really mean that ferritin should be stopped compared to...
Yes. Yes.
Okay.
Stop measuring ferritin and then things will become much clearer.
Can I actually emphasize this point that John is just making? In most jurisdictions in the world, ferritin costs about 10 times to 50 times more than assessing TSAT, which comes for free, more or less. And the global guidelines do explicitly make the statement that if you have a resource-limited situation or for whatever else, under other reason, like a dislike of ferritin, do not want to measure ferritin, that's totally fine. Use a TSAT less than 20 definition. That's no problem. The global heart failure guideline do say that.
Merry Christmas, Stefan.
I thought that was a peace offer.
It was indeed. Thank you.
Mark, we finalize this discussion. Thank you very much for all the experts joining us today.
Can I ask for a Christmas gift? The second, maybe not the first, but the second analysis of our IPD meta-analysis that I hope we can do next year should look at the iron dose given as a kind of time variable and the outcomes achieved. And you bet on higher doses not winning. I bet on higher doses winning.
Okay. 20 euros more?
No, a really good bottle of wine. And maybe a dinner with it.
Done.
Thank you.
Thank you very much. So now we have Gianluigi Savarese here to conclude the day, please.
So thank you so much, and I first of all thank you for joining us. I think it has been a long afternoon, almost evening, and so I thank you all for participation. Also to those who are online, and we are looking forward to seeing you tomorrow. We'll start 8:30, and for a very intensive day, but I'm sure you will get a lot from this fantastic faculty who is joining us. Thank you very much. Have a nice evening.
Thank you.
Bye. Thank you.